I don't know whether to tell welcome back or not for one, but I don't want to tell welcome back because it's the second consecutive delay that's happened. And anyways, I feel a little embarrassed to say we're going to start with rheumatology again. Okay. So we're going to start with heritable CTDs, that is heritable congenital disorders. I think it's too much hot, the laptop and the iPad. So that's why it's not working properly. But nevertheless, so we're going to talk about heritable CTDs. Heritable CTDs, we can divide into something called a tensile CTD. Then we have a compressive heritable CTD. Then we have the types of CTDs. And we need to, see some examples. What are the problems that are going to happen in each and every this kind of heritable congenital disorders? So as far as tensile CTD is concerned, the extracellular matrix will be the problem. So there can be problems. The extracellular matrix, I'm going to write as ECM. So, and extracellular proteins are there. So proteins can be defective, or the problem can be in the bones, tendons, and ligaments. So I can write bones, tendons, and ligaments over here. And they can also have problems in the skin, heart valves, and of course in the blood vessels as well. So this is where you're going to have problems predominantly as far as the tensile CTDs are concerned. As far as your compressive CTDs are concerned, the problem will be in the extracellular matrix, the problem will be in the extracellular proteins, and more than tendons, ligaments, and bones, the problem will be predominantly in the cartilages. So that's a very important point here. And when you see the examples for each and every disorder, you'll be understanding it much better. As far as the barrier CTD is concerned, so the problem will be in the base membrane predominantly, and that's going to be the characteristic key feature, the base membrane issues, like for example, an Alport syndrome, type 4 collagen problem. So that will come under barrier CTD. And the problem will be in the dermo-epidermal junction, DEJ. For example, epidermolysis bullosa is there. So let us move on to the examples now. As far as the examples are concerned, the first thing we're going to talk about here is the osteogenesis imperfecta. Very important, isn't it? Can anyone tell what is the defective collagen as far as osteogenesis imperfecta is concerned? What is the type of collagen that is defective in osteogenesis imperfecta? And obviously, everyone should be knowing that. Yes, of course, it's a type 1 collagen. So that is what is going to be defective in the setting of osteogenesis imperfecta. The details we'll be discussing after some time. And second, we have something called Ehlers-Danlos syndrome. I'm going to write as EDS, that is Ehlers-Danlos syndrome, but certain types of Ehlers-Danlos syndrome. And once again, the problem typically will be in the type 1 collagen in most cases. But even though we have vascular, I'm telling few varieties of Ehlers-Danlos syndrome will have problems in type 1 collagen, but we have something called a vascular type of Ehlers-Danlos syndrome, which has problems in type 4 collagen, type 3 collagen, which we'll be discussing subsequently. And after that, third problem is Marfan syndrome. Everyone knows what is the problem in Marfan syndrome. The problem is in fibrillin 1 gene, which we'll be discussing in a great detail in some time. And we have an entity called congenital contractural arachnodactyly. Contractural arachnodactyly. So where the problem is in fibrillin 2. Usually this is where the examiners tend to keep a twist. Most of the time, you know that fibrillin 1 is for Marfan, but in exam, if they ask fibrillin 2, sometimes you might be unaware of the fact that fibrillin 2 is not related to Marfan syndrome, and actually it's related to a disorder called congenital contractural arachnodactyly. And that is where the twist usually comes from. It's not fibrillin 1, it's all about fibrillin 2 that they're going to ask. And as far as the compressive CTDs are concerned, we know the cartilage is going to be the most important thing that's going to be affected. So we need to know that certain disorders like achondroplasia is associated with this kind of compressive CTDs, and we have something called epiphyseal chondrodysplasia. I can write epi stands for epiphyseal, and you have chondrodysplasia. That's an example of a compressive CTD, and we have something called a metaphyseal chondrodysplasia. So where each and every disorder, whatever you are seeing here, is actually based on the cartilage problems. So that is an example of a compressive CTD, which is going to predominantly affect the cartilages. And as far as the barrier CTD is concerned, the two classic examples are going to be Alport syndrome. Everyone must be knowing what is the problem in Alport syndrome. It's nothing but the type 4 collagen. Of course, we know it, so not a big deal. And second, We have epidermolysis bullosa, which is a problem in type 7 collagen. And that's also a question. Type 7 collagen. That's important as well. So let us see the problems with other types of collagen as well. So for example, we have seen about type 1 collagen, the best example, osteogenesis imperfecta. Then we have seen about this type 7 collagen. The best example is epidermolysis bullosa, and type 4 collagen. The best example is Alport syndrome. So what are the problems with other types of collagen? For example, if I ask you, what is the disease that is associated with the type 2 collagen? Can anyone answer? Type 2 collagen. So what are the diseases? I'm going to tell only important ones, not unnecessary ones that is given in all the tables in the textbook. So very important ones. What are the diseases that are associated with type 2 collagen? We have two diseases. One is very important, very commonly asked in exams. If you want to screw you to the core, this is how the questions will be framed. So type 2 is associated with something called a Stickler syndrome. Stickler syndrome. And we have another disorder called as chondrodysplasia type 2. So these are the two disorders that are associated with Stickler syndrome, or otherwise referred to as chondrodysplasia type 2. Then we have a type 3 collagen. What are the problems that are associated with type 3 collagen? As I told you previously, there is something called a vascular type of Ehlers-Danlos syndrome that will be associated with type 3 collagen. Some few types of Ehlers-Danlos syndrome are type 1 collagen, which I discussed already. Vascular type of Ehlers-Danlos is type 3 collagen. And we also have a type 4 collagen. Already we studied Alport syndrome, which is a very good example of a problem in the type 4 collagen. Another problem is Goodpasture. If you want to write Alport, I can write Alport also here. But another problem that is associated with type 4 collagen issue is Goodpasture syndrome. And apart from that, we have problems in type 8 collagen also. In type 8 collagen, you're going to see corneal dystrophy. That's type 8 collagen. Type 7 we saw already, that is epidermolysis bullosa, which is a very important question already. And we have a type 9 collagen. The problem of type 9 collagen produces something called a multiple epiphyseal dysplasia. Multiple epiphyseal dysplasia. And type 10 collagen. The problem of type 10 collagen will be called as metaphyseal dysplasia, which we have seen already. It's not equal to metaphyseal chondrodysplasia. This is metaphyseal dysplasia. And we have a type 15 collagen. The disease that is going to result as a result of type 15 collagen is called as Knobloch syndrome. K-N-O-B-L-O-C-K, Knobloch syndrome. Fine. So I told you only the important things, not all the things. So whatever is important and whatever is, predominantly can be asked in exam. That's what I told you. In this, if you want to pick up the most important, of course, osteogenesis imperfecta. Everyone knows that. And of course, the second most important is the epidermolysis bullosa, type 7 collagen. Everyone knows that. Alport, of course, important. Type 4 collagen, everyone knows that. Fibrillin 2, that's important because that's a common twist in the exam, congenital contractile arachnodactyly. Then vascular type of Ehlers-Danlos syndrome has been asked already. Type 2 collagen, Stickler syndrome asked already. Goodpasture as well as Alport syndrome is type 4 collagen asked already. And Knobloch syndrome, type 15 collagen asked already, known of the PGA exams. So remember, remaining type 8, type 9, and type 10 has not been asked in any exams right now, but still this is something that is very volatile. So I advise every student who's been reading this to probably, write this in a separate notebook, this kind of stuff in a separate notebook. And before going to the exam, you can just revise maybe some half an hour or 1 hour, just mug it up and go. So there is no point in understanding this stuff. Nevertheless, so the two diseases which we're going to discuss is osteogenesis imperfecta and second is Marfan syndrome. The first one is osteogenesis imperfecta. There are multiple different types of osteogenesis imperfecta. In that, type 1 and type 2 are very important. Type 1 is going to be more of a milder disease. It's not going to cause death. Whereas type 2 disease is going to be more of a lethal disease. But it's rare. Whereas, fortunately, the type 1 disease, which is mild, is going to be relatively common compared to that of the type 2 disease. And we know that osteogenesis imperfecta is a problem of a type 1 collagen. So type 1 collagen has two chains. One is called the alpha 1 chain and the second is the alpha 2 chain. So which means you have two genes. One is called a COL1A1 and you have a COL1A2. So this produces alpha 1 chain and this produces alpha 2 chain. So any of these things could be a problem. Very commonly the problem will be in the alpha 1 chain, that is COL1A1. So that is a collagen 1 alpha 1 chain. So that's where the problem will be usually in most of the cases of osteogenesis imperfecta. And of course, osteogenesis imperfecta is a structural disease. So as like most of the structural disease, you will have a inheritance pattern in the form of osteogenesis imperfecta. If they ask you how many types of osteogenesis imperfecta is there, totally, to be honest, there are 7 different types of osteogenesis imperfecta are there. But the type 1 and type 2 are the most important. As far as the clinical features, overall clinical features are concerned, we know that this disease is also referred to as something called a brittle bone disease. So they're going to have brittle bones in the form of increased risk of recurrent fractures, especially ribs and long bones are going to get fractured again and again. These patients have growth retardation because they don't grow properly and the bones are not proper. And over time, they develop skeletal deformities. That is due to deforming bones, and the bones are not strong, skeletal deformities. Then more importantly, in exam, the clue will be in the form of a blue sclera. And everyone knows that blue sclera is a feature of osteogenesis imperfecta, very important clue in the exam. And patients will have conduction hearing loss, conductive type of hearing loss. And it will be progressive in nature. By around 20s, the patient completely will lose the hearing because of severe conductive hearing loss. And it is very difficult to treat this also because even the ear ossicles will be very brittle and they will be broken easily. And the patients may have defective dentition also. Defective dentin. Because of that, they can have brittle teeth as well. So which means around a few years time, the patient might lose all the teeth and they may become, having to be dependent on the dentition. So external dentures. So brittle teeth is also a feature. And as far as the treatment is concerned, this is once upon a time asked in 2013. So bisphosphonates are going to be the treatment, most important treatment here. Even though this does not give dramatic response like in other disorders, but still it can be tried. And the only available option right now for treatment of osteogenesis imperfecta as bisphosphonates, or probably you have to treat with gene therapy, which is beyond the scope right now. So some important features of osteogenesis imperfecta. For example, if you see a child who's coming with blue sclera in exam with a lot of fractures, they don't give brittle bones. If they give that word, you will easily understand coming with a recurrent fracture, having a growth retardation and a progressive hearing loss and losing teeth. If they ask you the treatment, they won't ask you the disease. They will ask you the treatment. If they ask you the treatment, then in that setting, I can tell the only option I can try is probably the bisphosphonates. Next, coming to the Marfan syndrome, which is going to be more important for cardiological perspective as well as the general perspective, because Marfan syndrome has a lot of indices which you need to discuss. So as far as Marfan syndrome is concerned, we know it's a problem of fibrillin 1 gene. And because of that, this fibrillin 1 will not be present in normal amount. So they'll be diminished to a great extent. And it's an autosomal dominant disease. And one important point to note that disease, this disease is basically having a variable penetrance. So what do you mean by variable penetrance? They have both variable penetrance as well as they have variable expressivity. So what do you mean by variable penetrance? Anyone? There's a classic example of a disease with variable penetrance and variable expressivity. What do you mean by penetrance and what do you mean by expressivity? That's the question here. Okay. AV is telling that disease with different severity. That's what AV is telling. Penetrance is more of whether the disease is manifesting or not. So if you ask whether a disease is manifesting or not, I will call it as a penetrance. Expressivity is severity, like what AV has told, severity. So for example, if my father is having some, autosomal dominant mutation, and if I am also having the mutation, but I'm not expressing the disease at all. Yes, I'm not expressing the disease at all. I'm completely normal. So that's an incomplete penetrance. So now my child is born with severe disease. So that is possible. So this kind of whether they manifest or not is penetrance. Even despite harboring the gene, whether they manifest or not is what we refer to as penetrance. And it's not exactly a carrier because they harbor the gene. In a dominant mutation, you should not call it as a carrier. But despite having the genetic mutation, I'm not manifesting the disease. That is an incomplete penetrance. As far as expressivity is concerned, a different sort of an expression. For example, my father, in my case example, my father and my son are affected. My father would have expressed a severe disease and he would have died by 30-35 years of age itself. My son, on the other hand, will get a very mild disease and he might be living up to 70, 80 years despite having the gene and despite manifesting the disease. So whether they manifest or not is penetrance. If they manifest, how much they manifest is something like an expressivity. So, I mean, a very characteristic feature of autosomal dominant disease is the fact that they can have a different penetrance and a different expressivity. Marfan's is typical example where they can have a variable penetrance and a variable expressivity. And it's an autosomal dominant type of inheritance, and we know that. So when our fibrillin 1 is not there, so what are the problems? Remember, the elastin fibers are basically attached with fibrillin 1. If you take the fibrillin 1, the elastin fibers are attached by fibrillin 1 only. And there is another compound that is attached by fibrillin 1, that is extracellular TGF-beta. These are two substances that are anchored to a sort of by fibrillin 1. So when our fibrillin 1 is not there, if you're not producing fibrillin 1 in sufficient amounts, or fibrillin 1 is defective or produced in a mutated manner, so whatever may be the case, the elastin and TGF-beta both will lose support. So once they lose support, this elastin also will disintegrate. Elastin cannot be there without fibrillin, and there will be increased amounts of free TGF-beta. This increased amounts of free TGF-beta will result in increased production of matrix metalloproteinase. Once matrix metalloproteinase increases, they cause more disruption of the elastin. I mean, I can write like this, maybe I can put here. So they're going to produce more elastin disruption. So which means even though the problem is the fibrillin 1 protein, but elastin is the one that is affected to a great extent, which means you need to know what are the areas that are dependent on elastin. So we know that eyes are very dependent on elastin, heart, especially aorta, the great vessels, are dependent on elastin, and of course the skin are dependent on elastin. So these are the structures that are usually affected in the setting of Marfan syndrome. As far as the clinical features of Marfan syndrome is concerned, we have a criteria. Based on that only, we're going to diagnose. That's called a revised Ghent criteria. Revised Ghent criteria, that's the basis of diagnosis of Marfan syndrome. On revised Ghent criteria, like it's too much, but I'll try to explain a step-by-step manner. So revised Ghent criteria depends on two things. First, whether you don't have family history or you have a family history. So people without family history. And second, I can tell people with family history. People without family history. So I'm going to take four things into account. One is the aortic dilatation or aortic root dilatation. That's one feature I can take. Second, I can write ectopia lentis here. Ectopia lentis. And the third one, I can write it as systemic features. I'll tell what are the systemic features in some time. Then apart from that, finally, the genetic evidence, that is fibrillin 1 gene mutation. Fibrillin 1 gene mutation. As far as the diagnosis is concerned, I can diagnose based on aortic root dilatation and ectopia lentis. All right, that is first possibility of diagnosis. Second, I can diagnose based on aortic root dilatation and systemic features. This is the second way of diagnosis. I can put in a different color maybe. Aortic root dilatation and systemic features may be useful to diagnose Marfan syndrome. Or third possibility is I can use this ectopia lentis, and along with that, if there is a fibrillin 1 gene mutation, I can diagnose. And the fourth way I can diagnose is by this. If I have a aortic root dilatation and fibrillin 1 gene mutation, I can diagnose Marfan syndrome as well. So this is what the revised Ghent criteria is. Based on that, if I write 1, 2, 3, 4 on that, so 1 plus 2, or I can write as 1 plus 3 or 2 plus 4 or 1 plus 4. So this is how you diagnose a Marfan syndrome based on a fibrillin 1 gene mutation. I mean, based on the revised Ghent criteria, if there is no family history. On the other hand, if the patient is having family history, then in that setting, this family history itself is going to serve like, for example, like a fibrillin 1 gene mutation. So you don't really need gene mutation in this setting if there is a clear-cut family history. In that setting, if I need any one, for example, if I have an aortic root dilatation, or if I'm having an ectopia lentis, or if I'm having a systemic feature. So if any one is there among the three, that's enough to diagnose a Marfan syndrome in the presence of a family history. If there is no family history only, then most of the times you might be needing to have a fibrillin 1 gene mutation. Otherwise, it's very easy to diagnose Marfan syndrome, not a big deal. So the entire revised Ghent criteria is actually based on these features only. Without family history, with family history. Without family history means what are the ways to diagnose? Aortic root dilatation with ectopia lentis, aortic root dilatation with systemic features, ectopia lentis with fibrillin gene mutation, or aortic root dilatation with fibrillin 1 gene mutation. This is how you diagnose a Marfan syndrome based on revised Ghent criteria in a patient who is not having a family history. So now, we know that how the lens is going to be dislocated. That's a very easy question, and every second year student or third year student will be able to answer this. And I expect you to answer. So what is the type of dislocation of the lens that happens in your Marfan syndrome? Yeah, upward and outward. That is superotemporal. Correct, yes, that's a very trivial, easy one. So basic one. So in homocystinuria, it's inferonasal, and in Marfan syndrome, it is superotemporal. There is no need of any mnemonic or anything for this. This is a straightforward thing. So fine. So now the idea is to find out the systemic features. Remember, systemic features can be, classified into many things. Like aortic disease, you can put separately. Yeah, Divya is telling superb temporal. Maybe she's mistyped as superotemporal in the phone. It's coming as superb temporal, I think. But anyways, it's superb. Thank you very much for the answer, Divya. It's correct, superotemporal. And as far as aortic diseases are concerned, so what are the problems due to aortic dilatation? That is the next thing we are going to talk about. So as far as the aortic dilatation is concerned, it can result in aortic regurgitation, very common in Marfan syndrome. And it can result in aortic dissection. We know very common in the setting of Marfan syndrome, or it can result in ascending aortic aneurysm as well. All are deadly, isn't it? So these are the problems that you're going to develop as a result of aortic root dilatation. Then patients can develop mitral valve prolapse, very important. Then the patients can develop berry-aneurysms, very important as well. One of the important reasons for secondary development of berry-aneurysms in the brain is your, like Marfan syndrome. And in exam, you'll be thinking about ADPKD, but Marfan syndrome is also one important feature. And they can have a variety of musculoskeletal features. Musculoskeletal features in the sense the patient will be tall, very thin built, and they will have a joint hypermobility. And we know that, joint hypermobility. And typically, they tend to have this slender fingers, this thin and slender fingers. This is what we refer to something called arachnodactyly, like a spider finger. So slender and thin fingers, long, slender, thin fingers. So like spider spider kind of a scenario. So spider legs. So that's called arachnodactyly. That's where the name came. And they can have problems in the chest also. Like, for example, you can have a pectus carinatum. At the same time, we can have a pectus excavatum. If I ask whether pectus carinatum or pectus excavatum, which is commoner in Marfan syndrome and which is really specific for Marfan syndrome, pectus carinatum or pectus excavatum? Of course, it is carinatum, not excavatum. Carinatum is relatively more specific for Marfans compared to that of excavatum, and it is more common in Marfan compared to pectus excavatum. Pectus carinatum is what we refer to as a pigeon chest, and excavatum is what we refer to as something called a funnel chest. This is a common terminology. And carinatum has more value in Marfan compared to excavatum. And they can have a flat foot. The other name for flat foot is pes planus. And they can have scoliosis. Typically, the scoliosis will be more than 30 degrees. And I'll tell you how to find out scoliosis by a simple test called Adams test. And then we can have reduced elbow extension in these patients. Elbow extension will be defective and it will be reduced and not be the full category. Usually it is 180 degrees, but in Marfan syndrome patients, it will be less than 170 degrees. And apart from that, the patients can get skin stretching and they can get stretch marks because of that. And there are some eye features also. We know the eye features, the most important is ectopia lentis. And if it happens, it will usually happen bilaterally, not unilaterally. And the most common, area where it dislocates is the superotemporal region, as we all told. And as far as the face is concerned, they will have something called a dolichocephalic face. It means a long, elongated face. This is what we refer to as a dolichocephaly, one of the commonest signs in Marfan syndrome. You can remember Abraham Lincoln. long straight face, dolichocephalic face, and they will have a high arched palate. Then CNS, as far as the central nervous system is concerned, one important thing is dural ectasia. Loose dura that will result in the formation of a dural sacs, which I'll show you in some time. So what do you mean by dural sacs? And one important thing that you need to know with regards to Marfan syndrome is the fact that there is no mental retardation. That's very, very important. Their IQ is completely normal and there's no mental retardation. It's not going to affect the IQ in any way. So it's going to affect the other areas, but there is no mental retardation like many other congenital problems that you encounter. So each and everything is important, can be an exam question. But before that, let us see some of the features of the Marfan syndrome. So this is a characteristic example of a lens dislocation in the patients with Marfan syndrome that is happening in the superotemporal region. And at the same time, these are generalized features of Marfan syndrome where they can have winging of the scapula, they can have scoliosis. You can see the spine is like this. And that is, because of the scoliosis, your pelvic tilt is there. How to find out scoliosis clinically is by using something called an Adams test. So what do you mean by Adams test? Ask the patient to bend down, and here it is not there. Ask the patient to bend down. Once you ask the patient to bend down and see their buttocks. So usually both the buttocks and the hip should be in the same horizontal plane. Suppose if one is higher than the other, so then that indicates the presence of scoliosis. This is a simple test that can tell you that the patient is having a scoliosis. So that's called Adams test, and you can see these patients are having arachnodactyly, and this is another example of arachnodactyly here. And this is another example of arachnodactyly. These are some special signs like thumb sign and wrist sign. So you know what you mean by thumb sign. So this is how you do a thumb sign. So when you ask the patient to put the thumb into the palm and you make a fist like this, the thumb will exceed the ulnar border. This is ulnar border. So thumb will exceed the ulnar border of the palm by at least 1 centimeter or more. So that is the definition of positive thumb sign. And you have a wrist sign. So wrist sign is nothing but how you are seeing here. So you're going to encircle the wrist with the thumb and the little finger. So when you encircle like this, so usually at the level of the radial styloid. So again, the point is like you should not do everywhere. At the level of the radial styloid, if you do, you can try to encircle the wrist. So usually the thumb and the little finger will not overlap. But if there is a substantial overlap, but to be specific, if the overlap is in such a way that it exceeds the nail bed. So overlap is exceeding the nail bed. So it is going beyond that. So in that setting, you can think about a wrist sign positivity. And that is one of the important key features of Marfan syndrome. Clear? So what is the other name for thumb sign? Thumb sign is also referred to as something called a Steinberg sign. And what is the other name for wrist sign? Wrist sign is also referred to as something called a Walker-Murdoch sign. Walker-Murdoch sign. Thumb sign, Steinberg sign, wrist sign, Walker-Murdoch sign. So these are other names for that. Apart from that, you can see the root dilatation here. Usually speaking, the aortic left ventricle and the aortic root should not be equal. In fact, the aortic root size should be less than the left ventricular size. This is an example of a cardiac MRI with a reconstruction, 3-dimensional reconstruction, where you can see that here the aortic root is basically more than the dimensions of the left ventricle. So since it is more than the dimension of the left ventricle, that is clearly abnormal, and that's really bad. So this is a significant aortic root dilatation, and that's really important in a clinical setting. So this definitely should not be equal or more. So definitely left ventricle should be more. So here aorta is more. So that's clear-cut aortic dilatation. And you know what is this view in the heart? So what is this view? You have been studying cardiology for long, isn't it? So what this view is? What is this view? Yeah, this is a Plaque's view you're talking about. This is not apical. This is a Plaque's view. That's a parasternal long axis view, where you're seeing the right ventricle here. This is the aorta. This is the LV outflow tract. This is the left atrium. This is the mitral valve, and you're seeing the left ventricle here. So, simple, isn't it? That's all. So what you are seeing here is I'm comparing the aortic root size, where you can see there is a significant dilatation of the aortic root. So this is the aortic valve, and there's a significant dilatation of aortic root, and it is almost equal to that of the left ventricular dimension. So that's considered to be an aortic root dilatation. And if you can see this kind of finding, this kind of sacs in the dura mater, this is suggestive of a dural ectasia. And dural ectasia is one of the very common entities that happens in patients with Marfan syndrome, and they are really, really important in exam settings. They might give any one of this, because why I showed you this images is because they can give one of these images and they can ask you the questions on Marfan syndrome. So be careful about that. That's why these are important. And apart from that, wrist sign and thumb sign we have seen, and we have something called the upper segment lower segment ratio also. We have upper segment lower segment ratio. As far as the normal upper segment lower segment ratio is concerned, it is to be somewhere around 0.9, which really tells that lower segment is more than the upper segment. So that's very clear from the normal ratio itself. In Marfan syndrome, what happens is the lower segment becomes even more bigger than that of the upper segment, which means the ratio will be even more lesser. Normally itself, the lower segment will be more than upper segment. But in Marfan syndrome, it will be even more lesser. For example, if the ratio is less than 0.85, then you can think about a Marfan syndrome. So that's what you will see in Marfan syndrome, which means the lower segment will be even more bigger in the setting of a Marfan syndrome. So that's one point that you need to know. That's an upper segment by lower segment ratio. How to measure? Not now, maybe in 2.0. Definitely not needed right now. And apart from that, there is something called the arm span by height ratio. So arm span height ratio. Normally, arm span will be more than the height to some extent, like maybe by plus or minus 1 to 4 centimeter. So similarly, arm span by height ratio should be only borderline high. Suppose if the ratio is extremely high, if there is an increased arm span by height ratio, like more than 1.04, then again, that is suggestive of a Marfan syndrome. Similarly, if you take the arm span minus height, in a healthy adult, in a female, it should be up to 1 centimeter is okay. In a male, up to 4 centimeters is okay. If it is more than 4 centimeter, then again, that is indicative of a Marfan syndrome. That again tells you that the patient is having a significant increase in arm span compared to that of the height. And that's a very important index as well. And third, we have something called a metacarpal index. We have something called a metacarpal index. As far as the metacarpal index is concerned, we take the length of all the metacarpals. I mean, metacarpals, not this, sorry. We have the metacarpals here in the X-ray. So we take the length of all the metacarpals and we are going to divide it by the width of all metacarpals. That's what we're going to do. If this index is more than 8.4, then it is indicative of Marfan syndrome, which means what we are doing here is sigma length of all metacarpals divided by sigma add width of all metacarpals. So of course, length will be more. But if it's very, very high, like it's more than 8.4, then which means it's a thin, slender finger with reduced width of the finger. So that's what it means. So that's an indirect way to prove the arachnodactyly. So that's indicative of a Marfan syndrome again. That's what you'll be seeing. And as far as the management is concerned, there is no special management for Marfan syndrome. It's only treating the complications. That's how we're going to treat. So mostly the most important indication most important investigation as far as Marfan syndrome is concerned is the screening echocardiogram. That's what you need to do. Screening echo is very important in the setting of Marfan syndrome, and see the aortic diameter periodically. Suppose if the aortic root, that is the aortic root diameter, like is less than 4.5 centimeter, you're just going to observe, and you're only going to do yearly echocardiogram. Annual echocardiogram is enough. Suppose if the aortic diameter is more than 4.5 centimeter, then in that setting, it's better to do a 6-monthly echocardiogram. 6-monthly echocardiogram. And if the patient is having aortic root diameter of 5 centimeter, then in that setting, you have to do a surgery. Very important point. In other people, we take 5.5 centimeter or 6 centimeter as a cutoff. It will be a little higher, but in Marfan syndrome people, usually you do surgery at more than 5 centimeters. When the aortic root is dilated to more than 5 centimeter itself, you have to do surgery. So now they will definitely ask you one thing: what is the indication for surgery? Aortic surgery. What are the indications for surgery? Number one, we know more than 5 centimeter, definitely it's an indication for surgery. Second, if it is less than 5 centimeter, Plus, if you have any one of the following features, like for example, if there is a rapid growth, like for example, if it is more than 0.5 centimeter per year, so which means if it's a rapid growth, more than 0.5 centimeter per year. So in that setting, you can do a surgery. Or if it's less than 5 centimeter, if the patient is having a significant aortic regurgitation, for example, I can talk about a moderate to severe AR, or I mean, even moderate AR will be confusing to your level because there are so many sub-indications other than moderate AR. So I can write severe AR. The patient is having a severe AR along with aortic root dilatation, even if less than 5 centimeter, you can go for surgery. Or the patient is having a family history of dissection. Already somebody in the family would have got a dissection, they have died sometimes. So if the family history of dissection is there, then in that setting also, you can do the surgery. So these are the 3 indications where you can do surgery, aortic root surgeries, even if the aortic root diameter is less than 5 centimeter. But more than 5 centimeter is a definitive indication for surgery. And Riju is telling surgery people told 4 centimeter as the cutoff. My God. I mean, 4 centimeter is a very common thing I will be seeing even normal individual. Like it will be around 3.5. But around 30-40 years itself, there are so many people who are coming with 4 centimeter aortic root, and Marfan syndrome generally will have a little higher diameter only. If I take all the patients with 4 centimeter, then I think each and every Marfan syndrome patient will be taken for aortic surgery. Anyway, I'll verify that, but I don't think so. This is from cardiological perspective. Anything more than 5 centimeter, definite indication. If it's less than 5 centimeter, then you should have some strong indications to do surgery like rapid growth or probably significant aortic regurgitation or maybe family history of aortic dissection may be helpful. Clear? Suppose if you want to know the indication for surgery for ascending aortic dilatations, I mean, what indications for surgery for different indications. Already I told you for abdominal aortic aneurysms, for AAA, it is 5.5 centimeter. I told you that's the cutoff for doing surgery. Then we have Marfan syndrome, where the usual cutoff will be 5 centimeter. That's the number that you have to know. As far as I know, then for ascending aorta, the cutoff will be 5.5 centimeter again. Clear? So this is how you're going to do a surgery. So these are the thresholds for surgery as far as the aortic dilatation is concerned. So for abdominal aortic aneurysm, 5.5 centimeter, which I've discussed already. For Marfan's, 5 centimeter, we have discussed already. I told you that's the threshold. And for ascending aortic dilatations, 5.5 centimeter is going to be the surgical cutoffs. And there is a difference between ascending aorta and descending aorta also. I mean abdominal aorta and thoracic aorta. For example, AAA and ascending aorta are a little different because Riju asked this, I'm telling all these points. There is some differences there, AAA versus ascending aorta. As far as the plane size is concerned, you know, in AAA it is more than 5.5 centimeter, whereas in ascending aorta, it's again same 5.5 centimeter only, except for patients with Marfan syndrome, where I'll be keeping a cutoff of 5 centimeter. Or you can take the expansion criteria also. If the increase in diameter is more than 1 centimeter per year, as far as the abdominal aorta is concerned. But on the other hand, if you take more than 0.5 centimeter per year in the setting of a ascending aorta, that's an indication for surgery. So don't confuse with ascending aortic, abdominal aortic aneurysms, which you have discussed already in cardiology, because in abdominal aorta, I'd have told 5.5 and 1 centimeter per year is the cutoff. But whereas in ascending aorta, it is 5.5 centimeter and 0.5 centimeter per year is the cutoff. Remember, clearly in Marfan syndrome, it should not be 5.5. It is actually 5 centimeter. Whereas in other cases, it is 5.5 centimeter. But in Marfan syndrome, once again, it is 5 centimeter. It is less than compared to that of the general population. And similarly, as far as the expansion is concerned, for abdominal aortic aneurysms, it is more than 0.1 centimeter per year. Whereas in ascending aortic aneurysms, it is more than 0.5 centimeter per year. So these are the differences that you need to know, which are very important for exams. Then how will you treat? What is the medical management of Marfan syndrome? Medical management, everything will be related to the aortic root only. So the first medical management, of course, is going to be the beta blockers. Very, very important. Because they reduce the heart rate. Once they reduce the heart rate, amount of force that is generated by the heart will be less. If the amount of force that is generated by the heart is less, the amount of the momentum of blood that is going across the aorta will be less. If the amount of momentum of blood that is going across the aorta is less, means in the root, the wall stress and tension will be less. If the wall stress and tension will be less, means then the progression of aortic root dilatation will be less. That's why beta blockers are very good in the setting of Marfan syndrome. But there is one area where beta blockers should not be used. What is that area? Can anyone tell where beta blockers should be avoided in the setting of Marfan syndrome? They're very good basically, but in one area it's not very good. What is that? Aortic root dilatation with one problem. If it's there, you cannot give beta blockers. I mean, in the sense like it should be avoided as much as possible. Not HOC. I'm talking about aortic regurgitation. Avoid in patients with severe aortic regurgitation. Why you have to avoid in severe aortic regurgitation? Because beta blockers will slow down the heart rate. Once they slow down the heart rate, they will increase the diastolic time. Since aortic regurgitation happens in the diastole, the regurgitation will increase. I mean, for that matters, in any patient with severe AR, not only with Marfan syndrome, you should avoid beta blockers. But apart from this one small problem, you can use beta blockers in all the other patients with Marfan syndrome. If they don't have severe AR, only mild AR, so it's not a problem. You can still give beta blockers. Then there is something called ARBs. ARBs are shown to be beneficial in the setting of Marfan syndrome. But remember, not AC inhibitors. This is peculiar. You'll be asking why. So why ARBs alone are beneficial in Marfan syndrome and not AC inhibitors. So yeah, angiotensin 1 and angiotensin 2, which acts on different receptors. Remember, angiotensin 2 is the one that acts on the RAS system. And we have separately something called angiotensin 1. Angiotensin 1 is there, angiotensin 2 is there. So angiotensin 2 is the one that is important for manifestations by RAS, renin-angiotensin aldosterone system. But whereas angiotensin 1, the main function is to upregulate the TGF-beta pathway, TGF-beta levels. Already in Marfan syndrome, we know that there are higher TGF-beta levels. And we have discussed the pathophysiology. This higher TGF-beta levels is the reason for increased matrix metalloproteinases, and that is the reason why you're getting some few excessive problems in Marfan syndrome. So what you can do is, if you give an AC inhibitor, because for formation of angiotensin 2, you need AC, angiotensin converting enzyme. So of course, you block the AC, block the RAS, block the angiotensin 2 production. That's all right. But here, it doesn't have any impact on the TGF-beta. So that's why AC inhibitors are not going to have much significant effect in Marfan syndrome patients, unless until they have associated hypertension. But on the other hand, if you give something like receptor blockers, like angiotensin receptor blockers, this can block AT2. I mean, AT2 they block predominantly, but to an extent they can block the AT1 receptors also. So angiotensin 1 receptors also. So you can downregulate the TGF-beta level. So if you downregulate TGF-beta levels, they have some decent benefit in the setting of aortic root dilatation and other entities. So that is the reason why they believe that in Marfan syndrome, angiotensin receptor blockers may be helpful to a certain extent. I think you can get. So the final take-home point is not all these things. So the final take-home point is very simple. Angiotensin receptor blockers, but not AC inhibitors, are basically effective in the setting of Marfan syndrome, which means I can write they are going to downregulate the TGF-beta levels, and that's how they're going to be beneficial. And this is the take-home point ultimately. Do you understand Marfan syndrome? I think this must be enough for exams as far as Marfan syndrome is concerned. Clear or not? So we'll move on to the next topic. As far as heritable CDDs are concerned, the importance is most on the Marfan syndrome and the osteogenesis imperfecta only. You don't need to really think about anything else. These are two things that will be asked in exams usually, most of the times. So then we need to know about, we need to know about the immunological pathways, because even though I'm not planning to take extensive hematology in this particular session, because hematology is more of a pathological discussion, and I have a lot of hematology given in my application itself. Already we have substantially covered hematology. I'm not planning to give a big amount of hematology in this, but I can cover a decent amount of immunological perspective. So how these drugs are working, and that's what I'm going to see here. So first of all, what we need to know is that the antigen presenting cells are the ones that present the antigens to the T cells. We know that. And these antigen presenting cells can present the T cell, present the antigens in a variety of manner. For example, they can stimulate the T cells to become T helper 1 pathway. They can stimulate the T cells to become T helper 2 pathway, and they can stimulate the T cells to become T helper 17 pathway, and they can stimulate the T cells to even become something called a T regulatory cell pathway. We know that. But let us see all these things in a nutshell, which is very important because most of the drugs that is used in rheumatology is going to be based on this particular pathway only. So listen carefully. So what I'm trying to draw. So first of all, let me draw the antigen presenting cell first. So remember, there are professional APCs, non-professional APCs, which you've been studying in pathology. Professional APCs are only two. One is macrophages and second is dendritic cells. These are the only two professional APCs that we have. Apart from that, the other immunological cells can become a non-professional APCs. So let us take a macrophage or a dendritic cell for that matters, which is going to function as antigen presenting cells. And these antigen presenting cells are going to present the antigens, of course, to the something called a naive T cell. So let us assume this is going to be the naive T cell. And this is an immunological synapse. We'll be discussing about that in detail later on. So that's something called an immunological synapse there that's happening. And the molecule that presents this is the MHC class 2, and this is the T cell receptor to be precise. And there are a lot of co-stimulatory signals are also involved in that, which we'll be discussing subsequently. So anyways, so remember, these APCs are well aware of what type of molecule they have ingested or what type of antigen they have ingested. To be honest, even though the pathways are not well regularized and it is extremely specific for a particular pathogen. On the other hand, if you see from an overall bird's eye view, these pathways, it will not make any sense. I will tell intracellular antigen. Suppose if you are having an intracellular antigen here, you will follow this pathway. But sometimes in textbook, the same intracellular antigen can stimulate a different pathway. So which means it's specific for a particular pathogen, but you cannot generalize like for all intracellular antigens, you will have a particular pathway only. For extracellular antigens, you have a particular pathway only. It's more of antigen specific. At the same time, this is conserved through evolution also, which means it is something which you can't tell right now. So as a whole, what I can tell is an intracellular antigen, if the APC swallows an antigen that is typically intracellular, they are going to stimulate the T cells to become a type of T cell or an activated T cell called as a T helper 1 T cell. So that's very important. So usually, as a whole, not always, as a whole, an intracellular antigen will make the naive T cell go towards a T helper 1 cell, T helper 1 pathway by the stimulation by the antigen presenting cell. Similarly, if the same antigen is extracellular in nature, if the T cell swallows an extracellular antigen for that matters, sorry, if the antigen presenting cell swallows an extracellular antigen for that matters, and again, they are going to present through the same MHC class 2 because the synapse is going to be made through MHC class 2 and the T cell receptor only, and it's going to be a naive T cell. And of course, once this kind of extracellular antigen related APC presentation is happening, most probably this T helper pathway, this T cell activation pathway will be moving towards a T helper 17 clone formation. So this is called a T helper 17 pathway. And now the question automatically comes, first of all, how the MHC, how the antigen presenting cell knows whether it's intracellular antigen or extracellular antigen. And the second question comes, how APC can make or educate the T cells to become a T helper 1 or a T helper 17 cell. So that's again cytokines. Once APC is very easy to know. So they know that whether intracellular antigen or extracellular antigen, and how to educate the T cell based on whether it's intracellular or extracellular based on the cytokines, of course. So if the APC releases a cytokine called as IL-12, that is interleukin 12, so then that T cell that is stimulated by interleukin 12 will usually proceed towards a T helper 1 pathway. Suppose if the interleukin that is produced by the antigen presenting cell is typically an IL-23, interleukin 23, in this regards, your the stimulation of the naive T cell in this regards by interleukin 23 will be usually means that they will be resulting in the proliferation of T helper 17 clone, or they will move towards the T helper 17 pathway. This is one way where you can regulate what kind of T helper cell response that you need. Nevertheless, so once the T helper 1 is formed, T helper 1 itself generates a sort of an immune response, because there are some T helper 1 signature cytokines are there. So there are some signature cytokines of T helper 1 pathway. One is of course going to the TNF alpha, and even more, a signature cytokine if you ask, that is interferon gamma. Interferon gamma is a very important signature cytokine of T helper 1 pathway. And interferon gamma has multiple functions. And one of the important function of interferon gamma is to increase the vascular permeability. And that is the reason why you get that tuberculin reaction in TB whenever you put a Mantoux test. So increased vascular permeability, causing skin induration and all. And it can happen widespread in the body also. That's a very important function. And this interferon gamma also can stimulate the B cells to produce antibodies. But even though it's not very important, but still they can produce antibodies. As far as TNF alpha is concerned, TNF alpha has some specific functions and specific roles. For example, the most important function of TNF alpha is to activate and recruit more macrophages into that area, because they wanted to kill that intracellular pathogen. So which means I can write more and more macrophages that are going to come into that area, influx into that area. And these macrophages are going to release certain cytokines of their own, which are typically called as acute phase reactants. You have IL-1, IL-6, and again tumor necrosis factor alpha. The more TNF alpha they will secrete, more IL-6, more IL-1. And of course, IL-1 is going to stimulate more T cells, and TNF alpha is going to produce more and more macrophages. So more macrophages will be recruited to that area. So this is a kind of a response that you get expect in a T helper 1 pathway, which means there are some classic cytokines that are involved in the T helper 1 pathway: interferon gamma, TNF alpha, IL-1, IL-6, and of course TNF alpha in the final stage. So these are cytokines that are involved in the classic T helper 1 pathway, which we'll be discussing subsequently, and what they are creating basically. So what sort of response they are creating. So macrophage accumulation in a particular area will typically result in killing of an organism. That's why they're recruiting macrophages. Suppose if the organism is difficult to kill, in that setting, they first contain the organism. So the way of containing is what we refer to as a granulomatous inflammation. So if they can kill the organism, all right, they do kill the organism. But if they cannot kill the organism, it will result in something called a granulomatous inflammation. So whenever you see a granulomatous inflammation, which means it's very likely to be a T helper 1 pathway that's activated, and there are more macrophages in that area, and there will be a T cell, a collar. So for example, if you see a granuloma, in the center, you will see the antigen most often. And along with that, there will be a lot of reactive macrophages. These are called as histiocytes, and there will be giant cells. You would have said Langan type of giant cells, foreign body type of giant cells. I don't care about that right now. And this is surrounded by a well-defined inactivated macrophage. I mean, not inactivated. It's not fully activated macrophages. And of course, this will be surrounded by a collar of lymphocytes. We know that. So I'm drawing in blue because there will be a collar of lymphocytes. So this central activated macrophages called histiocytes, and surrounding macrophages with the collar of lymphocytes is what we typically call it as a granuloma. Even though there are a lot of variations in this granuloma, a typical example of granuloma is that. So you'll have a collar of lymphocytes. Whenever you don't have this collar of lymphocytes, we call it as a naked granuloma, which typically happens in the setting of sarcoidosis, where the collar of lymphocytes will be very, very poor because of energy in sarcoidosis that happens. So nevertheless, so this is a typical granulomatous reaction, and that's due to this classic T helper 1 pathway. Remember, T helper 1 doesn't mean it's a granuloma, but granuloma always means it's a T helper 1 pathway only. Usually that is the prominent thing there. And apart from this, you have a T helper 17 response. Why you should have a T helper 17 response? Because you believe it's mostly an extracellular antigen. The way of killing an extracellular antigen is by inducing T helper 17 cells. And once you activate this T helper 17 clone, and they're going to produce some signature T helper 17 cytokines. Signature T helper 17 cytokines means you have two interleukins. One is IL-17 and IL-23. These are the 22. These are the two signature T helper 17 cytokines. This IL-17 is going to activate the neutrophils, recruit more and more neutrophils. It's a neutrophilic response. They increase the neutrophils production, margination. At the same time, they attract more neutrophils like a chemokine. Clear? Interferon gamma. Yes, interferon gamma also has many other functions. But I mean, from a medical perspective, interferon gamma's most important function is vasodilation. I mean, that vasodilation. Why I told you that increased vascular permeability is because you need to understand the tuberculin sensory reaction sometime later. That's why that's very important. And IL-17 is going to activate the neutrophils, and they're going to recruit neutrophils to that particular area. And IL-22 increase the production of antimicrobial peptides. Antimicrobial peptides. Eleven is asking extracellular antigen also results in formation of T helper 2 cells. And please understand, again I'm telling, this kind of extracellular intracellular is only for our understanding. And there is nothing like, like you don't really like get only this T helper 1 with intracellular and T helper 17 with extracellular. There can be considerable overlap. And I'm telling you, it is more of an antigen specific and more of a pathogen specific rather than this a wide group of intracellular, extracellular antigen. That doesn't work here. It's more of a pathogen specific response. And same pathogen can elicit different types of response also. So you cannot really conclude that extracellular means it's only Th17 and intracellular means it's only Th1. So you cannot conclude like that. That's wrong. Reason you said that sarcoidosis does not have a collar of lymphocytes. That is, that's because two processes. One is energy. Number one, sarcoidosis patients are known to have energy, and a lot of T cells will be wasted in the formation of granulomas. In TB, you are forming granulomas only at selective places, but in sarcoidosis, you form granulomas everywhere else in the body, and you'll be wasting a lot of lymphocytes in different areas to produce a lot of granulomas. So ultimately, you will have some kind of T cell or a B cell exhaustion kind of a scenario where the body would have exhausted, and after that, if you form a granuloma, you don't have that sufficient collar of lymphocytes, and that is what we refer to as something called a naked granuloma, which I told you already. Fine. So you have, yes, IL-22 means they're going to increase the antimicrobial peptides, and this is very important. You can see that neutrophil recruitment, extracellular antigen, antimicrobial peptides, all these are very important for our mucosal immunity. So that is why this T helper 17 response is more often thought to be for a mucosal immunity. And even though it's important for many other places, but still it is thought to be more of a mucosal and a gut immunity. So where this becomes really important, that setting, because they can produce this antimicrobial peptides and they can recruit neutrophils, and especially extracellular antigen, which means outside the lumen, in the lumen, outside the epithelial cell, you have an antigen to prevent that from moving into the body. This kind of Th17 response becomes really important. And to be honest, HIV typically attacks the T helper 17 cells, and early stages of HIV, especially when it's not getting treated with highly active antiretroviral therapy, HIV virus preferentially targets this T helper 17 type of CD4 lymphocytes. So that is why the mucosal infections are extremely common in the setting of human immunodeficiency virus. That's also one point that you need to know, probably. And apart from that, we have a T helper 2 response, and T helper 2 response and T regulator response also. But before that, let us see the molecules that are important for this T helper 1 differentiation from naive T cell. Of course, you have a molecule called STAT4 that is important for this naive T cell differentiation of T helper 1 cell. So STAT4 is a transcription factor, and you have another transcription factor called TBET. So that's also important for the movement of the naive T cell towards the T helper 1 pathway. So which means whenever you stimulate with this interleukin 12, the STAT4 and TBET are the transcription factors that are going to be generated in the naive T cell that will move that particular T cell towards the T helper 1 clone. And as far as the T helper 17 response is concerned, the most important are going to be the STAT3 are going to be more important. And there is another transcription factor called ROR gamma T, that's called RAR gamma T, and some molecules of SMAD like SMAD4 is also important for the movement of naive T cells towards the T helper 17 pathway. And there is another response that can push the T cells towards the T helper 2 pathway. So we have not talked about the T helper 2 pathway yet. So this is a parasitic antigen. Suppose if it's a parasite, a little bit bigger, and it's a huge antigen which cannot be really swallowed, in that setting, you need to kill them by different principle. For example, in this, I'm going to stimulate the naive T cell to something called a T helper 2 pathway. T helper 2 pathway. T helper 2 pathway. So in this particular example, there are some cytokines that are involved. The most important cytokines that are involved is going to be the interleukin 4 here. Interleukin 4 is very important to convert this naive T cell towards and go towards a T helper 2 pathway. And once the T helper 2 differentiation happens, they produce some signature cytokines of the T helper 2 pathway. There are 3 signature cytokines of T helper 2 pathway. One is going to be the interleukin 4, second is going to be the interleukin 5, and third is going to be the interleukin 13. In 5 and you have interleukin 13. These are 3 important interleukins that are signature cytokines of the T helper 2 pathway. So the important function of interleukin 4, because it's a more of an allergic response. So T helper 2 is considered to be an allergic response. We know that. So they're going to increase the production of Ig, which means I can tell that this is important for class switching of the B cells to produce Ig, or plasma cells to produce immunoglobulin E. So they increase the production of Ig. As far as the interleukin 5 is concerned, they're going to activate the mast cells allergic response to produce histamine, and they can also activate the eosinophils. And as far as the IL-13 is concerned, they're going to actually activate the fibroblasts. At the same time, they increase the mucus production so that the parasite gets trapped in that particular area so that it can be killed easily by the eosinophils that are going to come into that particular area. This is a classic T helper 2 response. And there is an interesting theory. Like this T helper 1 and T helper 17 response is involved in a lot of autoimmune process because they are characteristic inflammatory pathways. Allergies are little rare. You don't really get. But the classic autoimmune diseases are usually going to happen because of hyperactivation of T helper 1 and T helper 17 response. So what has been suggested in one paper is that whenever you get childhood parasitic infections, for example, a childhood allergy, like parasitic infections like helminthic infections in the children, majority of your immunological responses will be directed towards the T helper 2 pathway, and there will be little like movement of this naive T cells towards the T helper on T helper 17 pathway. And I mean, that's been suggested as one of the reasons why in developing countries where there is a higher incidence of parasitic infections, you don't really get that much of autoimmune disorders. And that's really true. When you take the overall incidence of autoimmune disorders in developing countries, it's much lower compared to that of the Western countries, developed nations. So that is probably suggests as one of the reasons why most of the naive T cells in the childhood itself, they have been directed towards T helper 2 response, more of an allergic response rather than producing a T helper 1 or T helper 17 response, so that you have a lesser incidence of autoimmune disorders in the later part of the life. And that is also suggested that parasitic infections are thought to be like a, like a symbiotic relationship. I mean, there's too much, but anyway, that paper was discarded. But I'm telling an interesting hypothesis. That's very interesting, isn't it? So they think like that paper, author of that paper actually thought that parasites may be having a relationship, which means no parasitic infection literally kills the patient. And they have found like compared to autoimmune disorders and other infections, parasites don't really kill. Even though we call them as parasites, they cause only minor complications. But that's the reason that made the author to think that it could be a sort of a symbiotic relationship rather than a parasitic kind of relationship, where their presence actually reduces the incidence of future autoimmune disorders. But that's too much. That's not correct. But nevertheless, he's concluding in that way. That's very true, isn't it? We don't really get that much of autoimmune disorders in India compared to the Western countries. That's because of the probably increased amount of parasitic infections in the childhood. And you should have a regulatory pathway, because all this, what you have talked is about the inflammatory pathway. Yeah, hygiene autoimmune hypothesis came in House MD. Okay, Lingeshwar is telling. I mean, that hygiene hypothesis is not applicable for autoimmune disorders. Hygiene hypothesis given for bronchial asthma, but that's discarded. That's not the theory that we follow right now, hygiene hypothesis, where people with more hygiene are prone to get allergic response more. And that's thought because if you are not investing any of your T cells towards any of this pathway. So for example, if you are completely hygienic, your T cells will not be sensitized to like any of the allergic antigens. Suddenly you get some sort of an allergic antigen that is coming inside. There might be a hyperactivated response because the T cells doesn't know how to react, because if you have been exposing from the childhood means that's different. Suddenly if you're exposing without getting exposed in the childhood means suddenly you will enter a T helper 2 hyperactivated response, and that's the reason why you end up in developing a bronchial asthma and sort of stuff. So that's hypothesis not validated now, but still it's correct. Yes, hygiene hypothesis is important for this in the setting of a bronchial asthma. And more than that, you should have a regulatory pathway. Of course, I told you, it's not only about having inflammatory pathways, whatever we discussed, T helper 1, helper 2, and helper 17 pathway, but we need to have some sort of a regulatory mechanism also. As far as the regulatory pathway is concerned, so this pathway is to produce the T regulatory cells. So let us assume this pathway is mediated by TGF beta. So what makes the APCs to stimulate TGF beta, produce TGF beta? TGF beta is not produced only by the APC, it's produced by a number of other cells to downregulate the immune system. For example, you can stimulate a naive T cell to produce T regulatory cells using TGF beta. TGF beta is of course a cytokine, so they become T regulatory cells. These T regulatory cells are basically considered to be anti-inflammatory in nature, and they're going to regulate. And one of the important transcription factor that is important for production of Tregs is FOXP3. We know that FOXP3 transcription factor is activated in response to TGF beta stimulation by naive T cell. So once that is coming, that T cell is destined to go towards a T regulatory cell pathway. And T regulatory cells are going to produce two important anti-inflammatory cytokines. One is going to be the IL-10, and second is going to be the IL-35. IL-10, and second I can write IL-35. So two anti-inflammatory cytokines. As far as interleukin-10 is concerned, they are highly anti-inflammatory and inhibitory to T helper 1 pathway. And as far as IL-35 is concerned, they are highly anti-inflammatory and inhibitory to T helper 17 pathway. So they secrete two highly anti-inflammatory cytokines, that is IL-10 and IL-35. And that's how T regulatory cells act as a guardian. Like they prevent these things from getting hyperactivated. And because hyperactivation of T helper 1 and T helper 17 pathway can result in auto damage, resulting in autoinflammatory disorders. So you need some sort of regulatory mechanism. So T regulatory cells are implicated in autoimmune disorders. Yes, they are also implicated in autoimmune disorders, because if there is a imbalance between the T regulatory cells and the T helper 1 pathways, or if there is misfiring of the T regulatory cells, still you can result in development of autoimmune disorders. Yes, one of the important autoimmune disorders that can develop because of this FOXP3 mutation is called as IPEX. That's called immune polyendocrinopathy X-linked. I mean, yes, so it's involved in autoimmune disorders. It's a type of an autoimmune disorder. The T regulatory cells are not properly formed. It can result in a variety of autoimmune disorders. One of the important autoimmune disorders is IPEX because of FOXP3 mutations. IPEX, immune polyendocrinopathy X-linked. But nevertheless, this entire diagram idea is to tell the drugs that we are going to target at different areas. For example, I can target TNF alpha. So TNF alpha is a very, very important cytokine of the T helper 1 pathway and the macrophage related activation. So I can block this TNF alpha using a variety of drugs. You know, what are the drugs that can block the TNF alpha? So number one, I have infliximab, IFX. Second, I have etanercept. Then I have a drug called certolizumab. Usually that's available in pegylated formation. That's called certolizumab pegol. Then I have a drug called golimumab. And finally, my personal favorites, very commonly used drug, that is adalimumab. So these are different drugs that are going to block the TNF alpha. Of course, these TNF alpha drugs are used in a variety of disorders, which I will be telling in some time, where TNF alpha is a very important cytokine in the setting of rheumatoid arthritis. TNF alpha is a very important cytokine in the setting of Crohn's disease. Remember, most of them are granulomatous inflammation as well, like Crohn's disease, where you get a non-cascading granuloma in Crohn's disease also. So these TNF alpha drugs can be very, very effective in that situation. And you can block the interleukin-1 as well. There are some IL-1 blockers also. Can you tell what are the IL-1 blockers that are available? What are the interleukin-1 blockers that are available? There are two IL-1 blockers that are basically available. One is called anakinra. Anakinra is basically an IL-1 blocker. And you have another drug that is used in gout that is called canakinumab. Canakinumab is approved to use in acute gout because acute gout is thought to be a IL-1 beta mediated response. And it's mostly based on the auto-inflammatory pathway. We don't want to discuss that right now. So anyway, canakinumab is very important in that setting. And apart from that, what else we can block? We can block this interleukin 12 and interleukin 13 that you can do usually. So what are the drugs that block the interleukin 23? So once I block the interleukin 23, I can block the T helper 17 response. So for that, you need to understand interleukin 23 and interleukin 12 has two domains, and one common domain will be that is called a P40 domain. So let me draw here. So let me write that this domain is a common domain. That's a P40 domain in the interleukin 23, and then we have something called a P19 domain that's relatively specific for the interleukin 23. Then as far as interleukin 12 is concerned, we have another common domain here. That's a P40 domain is common. And apart from that, the second domain that is different is the P35 domain. So I can write like this: P35 domain is different. So that is P35 here, P40 and P35 here, P40 and P19. So there are some drugs that can block the different protein domains, thereby blocking like these cytokines, IL-12 and IL-23. So for example, there are some drugs which block the P19 domain. So once you're going to block the P19 domain, it will be a selective IL-23 blocker, which means that P19 is not present in IL-12. So that will be a selective IL-23 blocker. And there are many drugs are there in this setting. So one is called tildracizumab. We have something called tildracizumab. Then we have something called risankizumab. And we have something called a guselkumab. So all these drugs are basically approved for psoriatic arthritis and psoriasis. I mean, it's been experimented and it's been successful, because for psoriasis and even in rheumatoid arthritis, the IL-17 pathway is the TH17 pathway is very, very important. So that's why these drugs are effective in psoriasis, psoriatic arthritis, and rheumatoid arthritis for that matters. And it's been approved in that setting. Nevertheless, so they are specific IL-23 blockers, guselkumab, Guselkumab, guselkumab. And there are some drugs that can block the P40 pathways. I can write in a different color. So P40 can be blocked. So once you can block the P40, you can basically block both IL-23 and IL-12. So this will be IL-12 and 23 blocker. So this IL-12 and IL-23 blocker is what we refer to as ustekinumab. Ustekinumab is something that is used in psoriasis. It's used in ankylosing spondylitis. Majority of the seronegative spondyloarthropathies now have got approval for treatment with ustekinumab. So this is a combined IL-2 and IL-23 blocker because they block the common P40 domain that is common for both IL-12 and IL-23 in that setting. But this tildracizumab, risankizumab, and guselkumab will be specific IL-23 blockers. They will not be acting as IL-12 blockers, to be precise. And at the same time, we can block this interleukin 17 related response also, which might be used in certain autoimmune disorders. For example, you can block the interleukin 17 directly, or you can block the interleukin 17 receptor also. Suppose if you want to directly block the interleukin 17, you have two drugs in this setting. One is the famous secukinumab, and second one is the famous ixekizumab. Or you can attempt to block the interleukin 17 receptor also. Rather than blocking just the interleukin 17, I can block the interleukin 17 receptor. So that drug is called as brodalumab. So I remember basically based on the R that is present in brodalumab, because brodalumab has receptor, like R in it. So I believe that it's a interleukin 17 receptor inhibitor. Okay, all right. So we have these drugs. And coming to the allergic pathway, interleukin 2 pathway, P35 domain. We don't have any drugs for blocking the P35 domain right now. What I can tell about that, we don't have any drugs that block P35, and they have not devised it. And IL-4. So what are the IL-4 blockers? And if you block the IL-4, you can actually result in reduced production of Ig. So that is especially useful in bronchial asthma. We'll talk about that. So first, Ig itself can be reduced in number. So that's called as omalizumab. And IL-4 can be blocked. So basically, it's an IL-4 receptor kind of an inhibitor. So that drug is called dupilumab. IL-4 receptor inhibitor, that's a dupilumab. And then you can block the IL-5 directly. So what are the drugs that block IL-5? Is two drugs. One is the mepolizumab, and we have another drug called reslizumab. Reslizumab and mepolizumab are basically IL-5 inhibitors because they can reduce the eosinophilic response. And we have IL-13 inhibitors as well. One of the important drugs that block the IL-13 is something called as lebrikizumab. Lebrikizumab. So that is the drug that blocks the IL-13. Basically, it's an IL-13 inhibitor. Currently, many drugs are basically approved in the setting of treatment of bronchial asthma. That is, in the current guidelines, omalizumab is already there, dupilumab is already there, then mepolizumab and reslizumab are already there. Only lebrikizumab has not yet gained approval for the treatment of bronchial asthma, but all these drugs have been used in the setting of bronchial asthma, and they have been used in Chukch-Strauss syndrome. They have been approved for use in many hypereosinophilic syndromes. For Chukch-Strauss syndrome and hypereosinophilic syndrome, you know specifically the IL-5 inhibitor, that is mepolizumab, is the one that is approved right now for Chukch-Strauss syndrome and hypereosinophilic syndrome. As far as bronchial asthma is concerned, all the drugs have been approved except for the one that is lebrikizumab. Even though by the time you write NEET exam, it might get approved, I don't know. But apart from lebrikizumab, every single drug, whatever I told you in this, have been approved for treatment in bronchial asthma patients. So then what else is there? You can basically block the TGF-beta also. There are some TGF-beta drugs are there. So what are the drugs that block the TGF-beta? And it's used in idiopathic pulmonary fibrosis. Only one drug is there. That's an oral drug. That's the idea. Whatever drug till now I told you are subcutaneous or IV drugs, which means they should be given by parenteral route. The only one drug that is a known TGF-beta inhibitor, and it's a weak TGF-beta inhibitor, but it's approved for use in IPF, idiopathic pulmonary fibrosis. What is that? Because TGF-beta is very important for fibrosis. No, it's not nintedanib. Nintedanib is a tyrosine kinase inhibitor. It's not abatacept. Abatacept is not even coming into this picture. That is pirfenidone. Pirfenidone is currently approved for IPF, very weak TGF-beta inhibitor because TGF-beta is implicated in fibrosis. It's extracellular matrix kind of a picture. So it has a lot of, apart from its effects on T regulatory cells, it has a lot of effects on extracellular matrix, and increase in the extracellular matrix, your TGF-beta is very important. So in that setting, you can give pirfenidone, a very weak TGF-beta inhibitor. So it can be effective in the setting of idiopathic pulmonary fibrosis. And there is one more cytokine which you have forgotten to tell. For all the pathways, it's like an acute phase reactant. Any inflammatory pathway, if you're going to activate, for example, if you're going to go through this pathway, you're going to go through this pathway, you're going to go this pathway, that cytokine is very, very important. So that's one of the important acute phase reactants. That is interleukin 6. I cannot congest this anymore, so I can write separately here. That is interleukin 6. That's important for almost literally all inflammatory pathways. That acute, it's a very important positive acute phase reactant as well. It can be useful for all the pathways. So it's like a add-on. So there are some monoclonal antibodies that can block the interleukin 6, which will be effective for both Th1 as well as TLP2 pathway predominantly. So what is that? This thing, that is tocilizumab. We know that. Basically, tocilizumab is a receptor inhibitor rather than direct IL-6 inhibitor, but we do have direct IL-6 inhibitor in the form of something called a siltuximab. Siltuximab is a direct IL-6 inhibitor. So we know where tocilizumab is used. Tocilizumab, don't tell COVID, that everyone knows. And again, use in COVID is highly questionable, and only in selected patients it's response. I mean, it's going to show response, not in all patients. But apart from that, in autoimmune disorders, we are going to use in rheumatoid arthritis. We are using, okay. We are going to use in rheumatoid arthritis. We are going to use in multiple other situations also. So where you can use something called a tocilizumab. So then we have something called a siltuximab. As far as siltuximab is concerned, one indication that you need to know for exams for siltuximab, that is multicentric Castleman disease. Multicentric Castleman disease. Very rare disease, but we do see in tertiary care centers, 1 or 2 occasionally in a year. Especially if your center is very rich in hematology practice, then you should be able to see at least 1 to 2 per year. Multicentric Castleman disease. What is MAB? what MAB? That is tocilizumab and siltuximab. SILTUXIMAB, siltuximab, used in multicentric Castleman disease. It's a direct IL-6 inhibitor. Apart from that, tocilizumab, yes, all right. It is an IL-6 receptor blocker rather than a direct IL-6 inhibitor. So tocilizumab is an IL-6 receptor inhibitor. Clear? And remember, IL-6 can be easily downregulated by one important common drug, that is corticosteroids. Glucocorticoids. Glucocorticoids can downregulate IL-6 very easily, especially high-dose corticosteroids are powerful suppressants of interleukin-6. Steroids have effects on multiple pathways. Steroids have effects on IL-6, steroids have effects on T helper 1 pathway, steroids have effects on T helper 2 pathway. How they have effects on all the pathways? Because they downregulate the IL-6, which is also important for all the pathways. That's why steroids can be used everywhere for acute inflammation. And why steroids are useful? I mean, many students do ask like why steroids are helpful only during acute flare. It's not helpful during chronic maintenance phase. Two reasons. One, steroids have a lot of side effects if you're going to give chronically, but that doesn't have any purpose also, because only during acute inflammation, IL-6 will be elevated. During other process, IL-6 will not be that much useful. That's why steroids are useful only during that acute flare of the disease where IL-6 will be at its maximum. It is due to HHV7 and HHV8. No. We have multicentric Castleman disease due to multiple different reasons. HHV8 and HHV7 related multicentric Castleman disease is only a part of the MCD. MCD itself is divided into multiple entities, which I really don't want to tell right now. But the most important problem that happens in multicentric Castleman disease is something called an IL-6 TROM. That's what will happen in MCD, multicentric Castleman disease. And because of the IL-6 TROM, only you get problems in multicentric Castleman disease. And that's why we try to block that IL-6 by giving siltuximab. And that might be easy and that might settle the debate. And it's a very important column that I want to tell. So this one diagram, will tell you a lot of idea about where and what to use and what is important and what are the pathways that are available, and at the same time, how you block them with different kinds of monoclonal antibodies. So hope it will be helpful. I think you can just see this diagram once before going to the exam, so that you'll have a very clear idea about what antibodies are used at what places. Why I told you this? Because you need to know if you want to understand rheumatology, because from now on I'll be telling about infliximab, secukinumab, ustekinumab. So you should not confuse that drugs with anything. So you should be having a very crystal clear idea about each and every of these drugs. Okay. As far as arthritis is concerned, next we are moving on to the arthritis. Of course, we are going into the rheumatoid arthritis zone. But as far as the arthritis is concerned, the basic approach to arthritis is very important. The first question you need to ask in any form of arthritis is whether it's a inflammatory or a non-inflammatory arthritis. Ask whether it's inflammatory or non-inflammatory. Example is osteoarthritis for non-inflammatory arthritis, and the classic example is rheumatoid arthritis for an inflammatory arthritis. But nevertheless, even there are some types of osteoarthritis which are going to be inflammatory in nature, which can happen in that setting. And I think, is there any problem in the connection? Because I'm getting a problem in the connection. No problem. Okay. Cool then. So you're going to differentiate between an inflammatory arthritis versus a non-inflammatory arthritis. The most important feature as far as the inflammatory arthritis is concerned is going to be the early morning stiffness. I'm going to write as EMS. Early morning stiffness is a very characteristic feature of a inflammatory arthritis. So which will be typically more than 1 hour, at least 45 minutes. Whereas in non-inflammatory arthritis, usually it will be absent. Even if it is present, it will be less than 30 minutes for sure. It will not be more than 1 hour. It will usually be absent. So that's the usual scenario. It will not be present in the first place. And apart from the early morning stiffness, the pain in inflammatory arthritis is more of an AM pain, whereas in non-inflammatory arthritis is more of a PM pain. So we're talking about the AM PM time. So which means the morning they'll have more pain than the evenings and the nights, whereas in non-inflammatory arthritis, the evenings will cause more pain than the mornings. And night pain is again characteristic feature of an inflammatory arthritis only, because night the joint will be at rest. So a lot of night pains, like night during sleep, if you get the pain, that is usually suggestive of an inflammatory arthritis rather than a non-inflammatory arthritis. Apart from that, the pain and stiffness, we are talking about the pain and stiffness basically will improve with exercise. Improve in the sense I can tell they will decrease with exercise, or I can tell they are going to improve with usage of the joint. Whereas in the setting of a non-inflammatory arthritis, it's opposite. The pain can increase with exercise and more usage of the joint. That is the reason why they are having more of a PM pain rather than an AM pain. And what about the flares? There's something called spontaneous flares, which means even without doing anything, the disease might get flared up in the setting of inflammatory arthritis, where it is not a feature of a non-inflammatory arthritis. Remember, in non-inflammatory arthritis, the flare will be usually associated with more usage of the joint. Suddenly, a patient with osteoarthritis working more for maybe there is some function in the home, they are running around. So suddenly, like after 2 days, they'll come with severe pain. So that's kind of a association will be there. If you don't have that kind of association and they get a spontaneous flare, that's very characteristic of inflammatory arthritis. We really don't know when they're going to get a flare and when they don't get a flare. And as far as the constitutional symptoms are concerned, we know that's a characteristic feature of inflammatory arthritis. It's not a feature of non-inflammatory arthritis. And if you take the inflammatory markers like ESR and CRP, it's a feature of inflammatory arthritis. Of course, it's not a feature of non-inflammatory arthritis. And when you take a synovial fluid analysis, SFA, synovial fluid analysis, or if you do an arthrosynthesis and see, you will typically see something called an inflammatory fluid. So the typical definition of inflammatory fluid is total count in the synovial fluid more than 2000. That is WBC is more than 2000, where typically you will see a non-inflammatory fluid here, which means the WBC count will be less than 2000. Maybe more than 200, but definitely it will be less than 2000. And as far as the joint appearance is concerned, clinical features are concerned, joint appearance is what we are talking about. So in this setting, there will be swelling, redness, then warmth, and there will be tenderness as well. Remember, this is the characteristic, like the signs of inflammation that you see in the first chapter of pathology, in Ruber, Kehler, Dohler, tumor, functional Lisa. Of course, the fifth one is added upon later by Rudolf Virchow. The first four is given by someone called Celsus. You would have studied. So the same thing, the same findings, signs of inflammation is what we are seeing here. The swelling, redness, warmth, tenderness, all these are classic features of a inflammatory arthritis. And in a non-inflammatory arthritis, you might get a swelling, but redness is rare, warmth is rare, tenderness possible. But remember, tenderness in a setting of inflammatory arthritis and non-inflammatory arthritis is a little different. As far as tenderness is concerned, it is more diffuse around the joint in the setting of inflammatory arthritis. Whereas in the setting of a non-inflammatory arthritis, you will typically have a joint line tenderness. Only in the joint you will have a tenderness. Surrounding areas will be usually non-tender. They won't say that much of tenderness in the setting of a non-inflammatory arthritis. That's very characteristic again. And of course, there is one thing that you don't see, and that is very classically in the setting of a non-inflammatory arthritis like osteoarthritis, is the presence of crepitus. And range of motion can be decreased in both. So, but usually range of motion will be decreased very early in the setting of inflammatory arthritis, but it takes some time, and you will get little later in the setting of non-inflammatory arthritis. As far as X-ray is concerned, one finding that is common to both is the joint space narrowing. Joint space narrowing can happen in both inflammatory as well as non-inflammatory arthritis. There are exceptions for both. For example, joint space narrowing may not be seen in the setting of a gouty arthritis. That's characteristic example. Gout does not cause joint space narrowing. And similarly, instead of joint space narrowing, there can be joint space widening in the setting of hypertrophic arthropathy, which typically happen in the setting of acromegaly, where there will be cartilage enlargement. Because of that, you will develop arthropathy. And that's hypertrophic arthropathy, where you can see a joint space widening rather than a joint space narrowing. So, of course, there are examples for both, exceptions for both inflammatory causing joint space narrowing and non-inflammatory causing joint space narrowing. And more than that, the most important thing is that is erosions, that is characteristic feature of inflammatory arthritis, and you will see osteopenia. Typically, this erosions and osteopenia will be characteristically located in the juxta-articular location or otherwise referred to as periarticular location. That's where you see this bone loss and erosions. But erosions is not a feature. Cartilage may be eroded, but bone erosions is not a feature as far as your non-inflammatory arthritis is concerned. Instead, they'll produce subchondral sclerosis. That's characteristic. Subchondral sclerosis and cyst formation, very characteristic in non-inflammatory arthritis like osteoarthritis. And at the same time, instead of erosions, they can produce new bone formation, reactive new bone formation in the form of osteophytes that can mimic a loose body in the joint, osteophytes. So instead of erosions, here you can remember osteophytes. Instead of osteopenia, here you can remember subchondral sclerosis. Instead of bone loss, here there will be new bone formation, subchondral sclerosis and subchondral cyst formation. Here bones are eroded. Usually in non-inflammatory arthritis, the cartilage will be eroded. Like for classical example is osteoarthritis. And the question automatically comes, why this periarticular region is the one that is typically affected? Why this periarticular region is the one that is typically affected in the setting of a inflammatory arthritis? For that to answer, you need to know what is the something called a bare area of the joint. So as far as the bare area is concerned, you can clearly see that the articular cartilage is basically covering up these areas of a synovial joint, and some area is covered by the joint capsule also, the synovium also. Articular cartilage and the joint capsule as well as the synovium, all these things are covering up certain areas. But if you take this area that is not covered either by the synovium or that is not covered by the articular cartilage also, and this is what we refer to as a bare area, whatever is drawn in green. And whenever there is some inflammation that is going on in the synovium or in the joint, the first target will be the bare area, of course, because that is the one that is completely unprotected and not covered by cartilage, as well as it is not covered by the synovium as well. So that is why that area is the one that first goes for osteopenia, and that is the area that first goes for erosions also. As in this example of a severe case of rheumatoid arthritis, you can see that there are joint erosions on the side of the joint. So that's periarticular osteopenia and periarticular erosions. That's very characteristic. Juxta-articular, that's also the name that is given. Now you will be understanding why. And apart from that, other questions that you have to ask as far as the arthritis is concerned, what is the order of involvement of joints in an arthritis? Whether it is migratory involvement. So what do you mean by migratory? One joint will be in, for example, there can be a few joints that will be involved. Then that joints will completely resolve and there will be no more joint involvement. And after that, a new set of joints will be involved. And again, that joint will resolve and again, a new set of joint will be involved. So this kind of pattern is what we refer to as a migratory pattern of involvement. The classic example for migratory arthritis, if they ask you, is of course, acute rheumatic fever. Everyone knows that. And there is something called a disseminated gonococcal infection. That's important for exams. Disseminated gonococcal infection. So these are two situations where you can develop a migratory pattern of an arthritis. And of course, if you take the pattern, second pattern is something called an additive type of a pattern. Additive type of pattern. An additive pattern, one set of joints will start initially. Then after that, even before the resolution of these joints, a new set of joints will be involved again. So which means the joint keeps on adding one after the other. So this is what we refer to as an additive pattern. The best example and characteristic example of additive pattern is rheumatoid arthritis, RA. And after additive pattern, we have something called an intermittent pattern. So where the joints may be same joint. One joint is there, it will involve, it will cause arthritis, resolve. After some time again, the same joint will be involved. So this pattern is what we refer to as an intermittent pattern. The best example for intermittent pattern of arthritis is the gouty arthritis, first metatarsophalangeal joint. So that's very important. And at the same time, you have to know what is the actual joints that are involved. You need to know whether it's axial or peripheral joints that are involved. Based on that itself, you can understand a lot of things. For example, if you ask what are the axial joints are the ones that form the base or that protects the vital structures. So whatever that protects the vital structures and whatever that forms the base of the formation of the body, those are called as axial joints. For example, your spinal joints or axial joint, that's axial skeleton, then shoulder joints, then sternal joints, you have and shoulder joints, especially the glenohumeral joints. Then you have the hip joints. Like the shoulder, you have the hip joints. Then you have the pelvic bones. Then you have the sternal joints, sternoclavicular joints, sternal joints that form the axial skeleton, and sacroiliac joints in the pelvis, and temporomandibular joints, TMJ. Some examples of axial joints, which are very commonly involved in rheumatoid disease, rheumatologic diseases. So whatever that harbors your vital structures and forms the base of your body to perform your locomotive function, that part is what we refer to as the axial skeleton base. That is the base. As far as peripheral joints are concerned, or peripheral skeleton or appendicular skeleton is concerned, these are the basic locomotive function. So they're connected to the axial skeleton, but they are going to move easily. So this is an appendicular skeleton or peripheral skeleton or peripheral joints. Examples of peripheral joints from distal to proximal, you can tell you have MCP joints, MTP joints, then PIP joints, DIP joints of both upper limbs and the lower limbs. Then you have wrist joint, ankle joint, knee joint, elbow joint. Very characteristic examples of the peripheral joints. So there are some diseases which affect the peripheral joints, and there are some diseases that affects the axial joints typically. Let us see 3 disorders, for example. So you have rheumatoid arthritis, you have gouty arthritis, and you have something called seronegative spondyloarthropathies. With few exceptions are that's called SSA, where I can differentiate between axial versus peripheral joints. Remember, in rheumatoid arthritis, axial joint involvement is very, very rare. It can happen or may not happen, but peripheral joint involvement is the standard. At the same time, in gout, there is absolutely no involvement of axial joints. Axial joints can never be involved in the setting of a gout, but peripheral joint involvement again is the standard as far as gouty arthritis is concerned. As far as seronegative spondyloarthropathies are concerned, they can involve both axial joints as well as the peripheral joints. But depends again, because there are many different types of seronegative spondyloarthropathies. For example, ankylosing spondylitis will involve only axial joints. And there are other disorders. For example, you have psoriatic arthritis, you have reactive arthritis, that's what is called as Rhetus syndrome. Reactive arthritis is called as Rhetus syndrome. Then we have, IBD-related enteropathic arthritis, IBD-related arthritis. They involve more of a peripheral joint than the axial joint. So peripheral then axial joints. So it depends again. So SSA as a whole can involve both peripheral joints as well as axial joints. But I mean, the joint distribution also gives you a lot of clue regarding what kind of disease it could be. Then apart from this, the fourth question that you have to answer is the fact that what is the synovial fluid pattern? So in the synovial fluid also you can see some basic ideas. So when you do an arthrocentesis, when you do a synovial fluid analysis, what is the type of finding, whether it's inflammatory fluid or whether it's a non-inflammatory fluid? What is the type of fluid that you see? So I can write the WBC count here, the synovial fluid, and what is the differential count, or I can write the PMN percentage, what is the neutrophil percentage here, and then what will be the glucose levels, and finally, is there any additional findings like crystals that you can see, some additional findings that you can see in the synovial fluid. So we know that as far as the normal synovial fluid is concerned, the WBCs are going to be less than 200 and the neutrophils will be less than 10% in this setting. And at the same time, the glucose levels will be equal to that of the plasma. And as far as additional crystals are concerned, usually you don't see any crystals or any other additional findings. So this is a normal synovial fluid. So then if you take a non-inflammatory fluid, it can be in the range of 200 to 2000. Which means still there is an arthritis. So there will be some sort of inflammatory cell infiltrate will be there, but it will not be very high. So 200 to 2000. And still it will be less than 20%. It will be more of the time it will be equal to the plasma because it's a non-inflammatory fluid. And crystals usually don't see anything. But very rarely in the setting of osteoarthritis, you will be able to see this basic calcium phosphate crystals. These are called as basic calcium phosphate type crystals, which are nothing but apatite, hydroxyapatite or apatite crystals. So you can see in certain, usually 60% of the osteoarthritis patients may have this kind of apatite crystals with them. And as far as the inflammatory fluid is concerned, we know it will be more than 2000 WBC count. And usually the neutrophil percentage will be in the range of 50 to 75%. And glucose will be very much reduced here. And crystals, only two areas you will be seeing crystals. One is the gouty arthritis and second is the pseudogout, that is CPPD arthritis, calcium pyrophosphate deposition. In gout, you know what are the crystals you're going to see. You're going to typically see that monosodium urate crystals. MSU and CPPD, you will be seeing the CPP crystals, that is calcium pyrophosphate crystals. We know, we'll be explaining again, don't worry about that. In gout, you'll be having this kind of needle-shaped and negatively birefringent crystals. So two ends will be there. One is needle and negatively birefringent. So that's the two ends that you have to know with regards to gout. So monosodium urate, needle-shaped, negatively birefringent. And so CPP is concerned, it's rhomboid-shaped, more of rhomboid-shaped crystals and weakly positive birefringent, not a strongly positive, but a weakly positive birefringence when you look in the polarized microscope. And finally, we have a septic arthritis. So it's a septic joint. In the setting of septic arthritis, count will be more than 50,000 usually. You can write numbers itself. It will be more than 50,000. And typically more than 75% will be the inflammatory, neutrophil percentage, but usually it will be more than 90% usually. Glucose will be very much and seriously reduced, and there will be no crystals, but culture sensitivity may be positive. The joint culture, the synovial fluid culture may be positive in this setting. Okay, so these are going to be the synovial fluid analysis findings depending on whether it's inflammatory or non-inflammatory. So these are the four kind of approaches I've told you, whether it's inflammatory or non-inflammatory, whether it's migratory, additive or intermittent, whether it's axial or peripheral, what is the finding on synovial fluid analysis, that itself will give you a good idea about what kind of arthritis you're dealing with. And apart from that, as a summary, we can tell some specific points which are very important for exams. So number one, whenever in exam they give DIP involvement, it usually goes towards a psoriatic arthritis and it rules out a rheumatoid arthritis in exam. That's very important point. Whenever you have a PIP and DIP involvement, you always think about an osteoarthritis. Whenever you have a first CMC typically involved, first carpometacarpal joint involved, again, the answer will be osteoarthritis in that setting. And whenever MTP is involved, especially the first metatarsophalangeal joint is involved, it's very clear you're dealing with a gouty arthritis. Everyone knows that. That's typical gout. That's first MTP involvement in gout is what we typically call it as a podagra. And for example, if you're going to have MCP, PIP, and wrist joint involvement in exam, this typically goes towards rheumatoid arthritis. That's all. Usually, that is the idea as far as rheumatoid arthritis is concerned. And if you have only spine involvement, usually in this setting, it will be an ankylosing spondylitis most of the time. But remember, there are multiple other differential diagnoses which I'll be talking about. So many problems are there which can involve only the spine. But in exam, it usually goes towards think about an ankylosing spondylitis in that setting, if there is only purely a spinal involvement in that setting. And what else is there? Yeah, if knee is involved. Knee is the primary joint that is involved, then there could be a lot of things. For example, it could be osteoarthritis. And if it's a bilateral disease and more of an asymmetrical disease, think about an osteoarthritis because osteoarthritis is known to be more asymmetrical in nature. Or you can think about a CPP because in calcium pyrophosphate deposition is also most common that is affected is the knee joint. Even rheumatoid arthritis can have a isolated knee involvement. So whenever knee is involved, in an obese individual, think about a osteoarthritis in that setting. So, these are some of the joints that you need to know as far as your exams are concerned. This will give an overall clue. And eighth gold standard point that you know is any monoarthritis of the large joint. Monoarthritis of large joint. If they ask you the investigation of choice or first line investigation or a gold standard investigation, of course, it will be arthrocentesis and subsequent synovial fluid analysis. That is joint aspiration. That is the gold standard for any monoarthritis of a large joint, because here the priority will be ruling out a septic arthritis. That's why any monoarthritis of the large joint, the first thing that you're going to do is arthrocentesis and do a synovial fluid analysis and see whether it's a septic arthritis or not. That's really, really, really important point. That's very important in rheumatology also. Any monoarthritis of the large joint, do a synovial fluid analysis. And inflammatory monoarthritis we're talking about, not a non-inflammatory osteoarthritis. Inflammatory monoarthritis of the large joint, first investigation, always joint aspiration. Okay. Then we can move towards discussion on rheumatoid arthritis. So that's the first arthritis we're going to discuss after knowing about how to discuss on the patterns of arthritis. Saurabh Sinha is asking, in case of arthrocentesis, we give any prior antibiotic? Of course, no, because your idea is to rule out a septic arthritis, and giving even a single dose of antibiotic can bring down the findings very badly, and it might result in even poor treatment after that, because you might be falsely thinking it's an inflammatory arthritis and you will not be thinking it's a septic arthritis, because septic arthritis has typical findings. Suppose if the counts are 70, 80,000, I'll think of septic arthritis. If you give antibiotics and take a joint aspiration, it might be around 3,000 or 4,000, where you will be more often thinking about an inflammatory arthritis, and giving steroids in that scenario rather than antibiotic will result in a catastrophic outcome. So don't do that. Giving antibiotics prior is strictly avoided, and you have to work with orthopedician for that to understand this. They never give antibiotics. I've seen, like, even I tell it's okay, sir, please give antibiotics. I'll take care, no problem. They never give. They give antibiotics only at the time of joint debridement, or they take the sample, then only they give antibiotics. I don't know why they're very, strict about that. But even I'm not strict like that, but still orthopedicians are going to be very strict. They never give antibiotics before doing a joint aspiration or debridement. Because that's true in a way, especially in the setting of a prosthetic joint. Your Staph aureus contamination is extremely common, and they can be MRSAs also. So you need to really know the bug that is causing the problem. Otherwise, it becomes really, really difficult. So you have to understand the bug. That's why taking a culture becomes really, really important. And that's a good practice, in fact. So let us move on to the rheumatoid arthritis. Rheumatoid arthritis, of course, we know it's going to be common in females. It's a female predominant disease. And this female predominant disease is going to be only in a specific age group, which I'll be discussing in some time. So for example, as far as the age of rheumatoid arthritis is concerned, it's somewhere around more than 50 years of age. Very common age group is more than 50. That's the most common age group where you get rheumatoid arthritis. But you can split into 3 groups. One is less than 50, and the second is 50 to 75, and more than 75. In these groups, 50 to 75 seems to be the most common age group where you get rheumatoid arthritis. Less than 50 is the second most common age group where you get rheumatoid arthritis, and more than 75, it's unlikely to be rheumatoid arthritis. Usually beyond 75 years, you don't really get rheumatoid arthritis. So that's the take-home point here. It will be some other disease, not rheumatoid arthritis. And along with the history, you need to know that I can split into less than 60 and more than 60. And this female-male difference is usually seen in the less than 60 only. When you go beyond 60 years of age, your female-male difference will be lost to a great extent, and your females will almost be equal to that of the males. That's very important again. So suppose in rheumatoid arthritis, it's very common in females, which means females will be associated with the poor prognosis, or males will be associated with the poor prognosis. As far as rheumatoid arthritis is concerned, who will be associated with the poor prognosis, females or males who get rheumatoid arthritis? Very few are telling very few are telling females. Many of them are telling males, of course, which always means that females are going to have a poor prognosis. Female sex itself is a poor prognostic factor. It's common in females, but at the same time, females itself is a poor prognostic factor as well as rheumatoid arthritis is concerned. So this is a common notion I used to tell. After knowing the age of acquiring rheumatoid arthritis, for any autoimmune disorder, there are 2 things that are very important. So you have a genetic insult, and then on top of that, you should get some environmental insult. You get an autoimmune disorder. For example, rheumatoid arthritis in this setting. So which means you should have a genetic makeup that is supposed to cause rheumatoid arthritis. One of the strongest genetic link with rheumatoid arthritis comes in the form of HLA-DR4. You should never forget this. That's very, very important exam. HLA-DR4 is going to result in the development of rheumatoid arthritis. And as far as the environmental insult is concerned, it's going to be smoking, one of the strongest risk factors. They ask you the strongest environmental link to rheumatoid arthritis. Answer will be smoking. Very, very high risk. And you have other risk factors like pneumoconiosis, and having dental infections, dental or chronic oral infections, supposed to be a risk factor. And this is due to one important bacteria that's been implicated in development of rheumatoid arthritis called as Porphyromonas gingivalis. Porphyromonas gingivalis. So that's a very important organism. I'll tell you why this organism is important. So these are some of the risk factors, but if they ask you the strongest genetic HLA-DR4, strongest environmental, it is smoking, of course. And let us see the pathophysiology in an overall way, like that will be a little helpful for you. For example, whenever the patient smokes, so smoking will result in activation of certain enzymes called PADI. These PADI enzymes are naturally present in the body. That's called peptidyl arginine deaminase. So peptidyl arginine deaminase. Usually the function of the PADI enzymes is to convert the proteins to citrullinated proteins. This is called post-translational modification. Citrullinated protein, and this is what we refer to as something called a post-translational modification, which is a normal entity that happens in many of the proteins in the body. But in patients who are smoking, because of hyperactivation of PADI, there will be too much of citrullinated proteins, which means the normal proteins that should the certain proteins which shouldn't be citrullinated to only certain extent, which will be over citrullinated. So that's the problem here. Because of too much abnormal citrullation, this abnormally hypercitrullinated proteins might be recognized as antigens by antigen presenting cells. Because we know antigen presenting cells, they can recognize these as antigens, and these citrullinated proteins will be now presented by the MHC class 2 to, of course, the T helper cell. So this is a naive T cell, we know that, through immunological synapse. And there are multiple pathways where these T cells can be stimulated. But before that, here where comes the genetic link. So which means, so now you know that you need some MHC class 2 molecule to present this citrullinated peptide. So I can put the citrullinated peptides here. To present the citrullinated peptide, you need some MHC class 2 citrullinated. And that MHC class 2 is usually HLA-DR4. So which means this HLA-DR4 is one of the very important MHC class 2 molecules that has the ability to express the citrullinated peptides. So other MHCs are not really having that much efficiency in expressing the citrullinated proteins. And this HLA-DR4 is the one that has the highest propensity to express this citrullinated protein. That's why DR4 is a very important genetic link. And once expressed, these naive T cells are going to get activated. Once these naive T cells are activated, they can be going into different pathways. For example, they can become T helper 1 response. So where you know what's going to happen, or they enter into a T helper 17 response. Once you become a T helper 1 response, you are going to produce a variety of cytokines, TNF alpha, IL-1, IL-6, and interferon gamma, and so on. And the most important as far as rheumatoid arthritis is concerned is the TNF alpha, which is very important. And as far as T helper 17 response is concerned, which you have seen already, where it can result in the development of IL-17 and IL-23, very important cytokines, T helper 17 response. And this is going to be more of a macrophage-based response, you know that, and more of a granulomatous inflammation. This is going to be more of a neutrophil-based response. So both are activated basically in this setting. Sorry, IL-22. Correct. So this is more of a neutrophil-based response. This is going to be more of a macrophage-based response in this particular setting. But nevertheless, we can use drugs that target these pathways. And apart from that, whatever may be the T response, and the T helper stimulation will also result in the activation of B cells. Even though we have not seen that in the previous diagram, they're going to also result in the activation of B cells. These B cells, of course, are going to result in the formation of antibodies. These antibodies, of course, result in the production of complements, and there is a complementary damage as well. And these antibodies can do direct bit of damage, and these complements also can cause tissue damage. And these antibodies can be of many types. It can be some specific antibodies like anti-CCP. Instead of writing anti-CCP, I can write ACPA. That's called anti-citrullinated peptide antibodies, ACPA, because that's going to be very specific, because the basic underlying reason for development of this response is this citrullinated proteins, and that's expected because that's a specific antibody, that is anti-citrullinated peptide antibodies, ACPA. Or they can produce some non-specific antibodies like rheumatoid factor, which I'll be discussing sometime what do you mean by rheumatoid factor later on. So they can produce these non-specific antibodies like rheumatoid factor also. So probably evolutionary scientists tell why they develop rheumatoid factors because of the hypercomplementemic response, and they're going to produce a lot of immune complexes. As per the evolution, these immune complexes are basically removed by certain antibodies, and rheumatoid factor is probably important for removal of those immune complexes that are getting formed. And that's why in rheumatoid arthritis, too much of immune complex, like rheumatoid factor is also produced. That is to probably to remove the immune complexes, but that's creating some damage also, which we'll be discussing sometime later on. And these antibodies add on to the damage to the areas that have citrullinated peptides. Now you ask the question, why joints? That's the question. So why joints? Because these citrullinated proteins are present in too much numbers in the synovium. Number one, that's the area where you can see the maximum concentration of the citrullinated protein. So that's why the inflammation is mostly intense on the synovium of the joints. It can be seen in the blood vessels, so they can produce vasculitis. That explains the development of those rheumatoid nodules sort of a thing. They can be present in serosal layers, so which means that explains the development of pericarditis, pleuritis, peritonitis sometimes. And they are present in the heart valves as well. That explains the development of MR in many patients. And at the same time, they are present in the skin as well. And they are present in the lungs as well. That explains the development of ILD also. So which means, these are the areas that are going to be commonly targeted by this inflammatory cells, whatever you're talking about, this macrophages, neutrophils, and this antibodies, complements, all these things are basically going to target these areas. So because that is the place where the antigen concentration is the maximum. Here the antigen typically is the citrullinated proteins, and this hypothesis is what we refer to as citrullinated hypothesis. And this is going to be the most important as far as rheumatoid arthritis is concerned, because this ACPA is considered to be one of the most specific antibodies, and it's been proven that certain patients with rheumatoid arthritis have anti-citrullinated peptide antibodies that have been circulating 10 years before the diagnosis of rheumatoid arthritis. Suppose if I am not having any joint symptoms, no problem. Still, if I'm having ACPA that is circulating in my blood, that increases the risk of developing rheumatoid arthritis. I may or may not, that's secondary, but it can be seen. ACPA antibodies can be seen 1 decade before the clinical onset of rheumatoid arthritis. So it's something like that. So the ACPA is very important. It's very, very specific antibody. And rheumatoid arthritis is quite non-specific because it's been thought that it's to mop up the complements that are the immune complex that are formed, to mop up that this rheumatoid factor has come up. So that's what the hypothesis is. So if that is the case, then you should be seeing rheumatoid factor in many other conditions also. And yes, of course, we see rheumatoid factor in many, many other conditions. But nevertheless, there are a lot of areas where you can treat rheumatoid arthritis using targeted therapy. First, IL-6, as I told you, is very important for any inflammatory pathway, both Th1 as well as T helper 17. So it's a positive acute phase reactant. So it will be useful for all the inflammatory pathways. So you can target different areas. For example, first one, you have the non-targeted therapy. So non-targeted therapy are the classic DMARDs, the disease-modifying anti-rheumatic drugs that we talk about. So like, for example, you have a methotrexate and you have azathioprine. So these are non-targeted therapy. Basically, you don't target anything in particular. So where you can use to diffusely downregulate the immune system. Or probably you have some targeted therapies. These target therapies are basically biological agents. And sometimes it could be like your JAK inhibitors also, which we'll be talking about. So as far as the biological agents are concerned, you can give IL-6 inhibitor, like for example, tocilizumab. Before COVID, very commonly we use tocilizumab for your rheumatoid arthritis only. And we can give anti-TNF-alpha drugs. We know what are the anti-TNF-alpha drugs that are effective, like adalimumab, golimumab, infliximab, etanercept, and we have certolizumab pegylated formation. And we have IL-1 as well. So typically we use anakinra here, That's not very powerful drug, but still it is approved for use in rheumatoid arthritis. Then you can block this TLPR17 pathway by blocking IL-17 pathway. So you know what are the drugs that block IL-17 pathway? One of the drugs that's been approved is secukinumab. We know that. It's very, very important. Secukinumab has been approved. And ustekinumab is being tried in rheumatoid arthritis, but even though not with that much of success, but still ustekinumab, it's a combined IL-12 and IL-23 inhibitor, so it can block both the TLPR1 and TLPR17 pathway. Or you can actually block the immunological synapse. You can break the immunological synapse. I'll teach you about this in nephrology, how you can break the immunological synapse, which means there are some drugs that work on the immunological synapse so that they break the T cell recognition of the antigen. What is that? Here, your abatacept comes. Abatacept, and you have another drug called belatacept, which is used in post-transplant conditions. Abatacept is very important here. So that's also approved for treatment in rheumatoid arthritis. So you can remember like that sort of that breaks the immunological synapse, which means they're going to be down-regulating the antigen recognition of the T cells. So they cannot recognize the antigen properly. So that's sort of a drug called like abatacept. Or alternatively, you can block the production of antibodies by the B cells. How you can block the production of antibodies by giving certain drugs like rituximab and other anti-CD20 drugs. Rituximab is a very, very important drug in the treatment of rheumatoid arthritis because antibodies are going to be really, really important in causing the damage in rheumatoid arthritis. But rituximab is an anti-CD20 that is seen on the surface of mature B cells. So it's like an anti-B cell. We talked about that already. So they can kill the B cells. Once the B cells are killed, you will down-regulate the production of antibodies so that the damage done is actually quite less. So you have a lot of biological agents. These are targeted therapies we are talking about. And third group of compounds, we have JAK inhibitors. Remember, DMARDs are basically oral drugs. Biologicals are subcutaneous or IV drugs, which means they are parenteral drugs. JAK inhibitors are once again oral drugs. They are a different league. So what do you mean by JAK inhibitors? We have not talked about that. JAK inhibitors are something that are going to inhibit the JAK receptors. So remember, JAK receptor, I'll be talking about this in endocrinology predominantly. You have a receptor called JAK receptor, which is basically comes under something called a NRTK, that is called non-receptor tyrosine kinase. And there are certain ligands that work on the JAK receptors, that is NRTKs. These ligands are nothing but we called as TINS, TERS, GM-CSF, and growth hormone. This is a mnemonic I used to give. TINS, TERS, GM-CSF, and growth hormone. TIN stands for anything that starts with, ends with TIN. I don't want to tell in this setting. So you can talk about prolactin. You can talk about thrombopoietin, then erythropoietin. So whatever that starts with TIN, so ends with TIN. So TINs, prolactin, thrombopoietin, erythropoietin. So they act through JAK-STAT pathway. And TERS, what are TERS? TERS are interleukins or interferons, GM-CSF, growth hormone. All these things are going to act through this JAK-STAT pathway only. So if we design a drug that can block the JAK receptor, and they are called as JAK inhibitors or JAK inhibitors, and which means all the interleukins, whatever we're talking about, is going to act through the JAK receptors only. So there are some non-specific JAK inhibitors, which can block the interleukins action, but they're not very effective, to be honest, compared to these drugs because they are very non-selective and they block with a lot of inefficiency. But still, they can be used to down-regulate the immune response in the body. Like, for example, you have a drug called tofacitinib, which has been approved in many of the autoimmune conditions. And we have something called a baricitinib. So as far as the therapy and the pathophysiology of rheumatoid arthritis is concerned, this is what you need to know. So DMARDs, biological agents, different areas where biological agents act. And finally, you have the JAK inhibitors, which block the action of interleukins and interferons probably. That is tofacitinib and baricitinib. Tofacitinib has been already approved in the treatment of rheumatoid arthritis. So you can use these drugs to treat rheumatoid arthritis. And you have a lot of types of hypersensitivity reaction that's happening here. In fact, except type 1, everything is going on. For example, you see that this patient is having a type 4 hypersensitivity reaction that's going on. You can see that's a type 2 hypersensitivity reaction that's going on by the production of antibodies. And you can see this immune complex formation through complements means it's a type 3 hypersensitivity reaction that's going on. So except for this type 1, we have all the types of immune reaction that is going on. So of course, PG aspirant or any medical student will ask what is a prominent type of hypersensitivity reaction. That's going to be type 4 hypersensitivity reaction only. So that's going to be the most prominent of all, type 4 hypersensitivity reaction. And if they ask you among this T helper 1 and T helper 17 pathway, which is the prominent response, T helper 1 response or T helper 17 response in rheumatoid arthritis? T helper or T helper 1 or T helper 17 response? Riju is asking example of TERS. Example of TERS is interferons and interleukins. I mean, that could be a question exam. If they ask you the prominent clone of circulating T helper cells in a patient with rheumatoid arthritis is T helper 17 clone. So that's the majority, like the maximum number of circulating T helper clones in setting of rheumatoid arthritis is actually T helper 17 clones only. That's very important. We know that. Okay, fine. I think this must be enough, right? So do you understand this pathophysiology so that we can move on to the next one? Yes, of course. Okay. It's a very simple pathophysiology. Remember, I'm not going to talk about the Pannas formation. Pannas is just proliferation of the synovium that can happen in many of the disorders. But even though Pannas is first described in rheumatoid arthritis, Pannas just means it's an inflammation of the synovium that results in reactive thickening of the synovium due to proliferation of the fibroblasts, smooth muscles, macrophages. All these things will form a soup and they're going to cause thickening of the synovium. And that synovial thickening is what we refer to as Pannas formation. And that Pannas itself contains a lot of inflammatory cells. And it starts coming towards the joint. And when it touches the joint goes for a lot of erosions. And that's why the importance of Pannas is there all about. So you would have studied in pathology. Nobody in exam is going to ask what Pannas is and how Pannas is formed. But nevertheless, it's just a soup of cells of the synovium, inflammation, everything. They cause enlargement and thickening of the synovium. That's what we call it as Pannas formation. So basically, as far as the rheumatoid arthritis is concerned, you have 3 phases of the disease. So one phase is what we refer to as initiation of autoimmunity. Initiation of autoimmunity. And usually during this initiation of autoimmunity, the patients will not have any signs and symptoms of rheumatoid arthritis, but they may have positive rheumatoid factor ACPA, which means antibodies may be circulating already at the time of initiation of autoimmunity itself, but they will not have any signs and symptoms. So that is called as initiation phase. Second one, we have something called a provocation of autoimmunity. Provocation of autoimmunity, where the patient starts getting signs and symptoms of rheumatoid arthritis, and there is going to be increased titers of rheumatoid factor and ACPA. Compared to the baseline, the titers will start increasing in this phase. And during the provocation phase, once again, you can divide into 2. One is called early undifferentiated phase, which means there will be a diffuse arthritis. You will not be able to clearly tell that it's a rheumatoid arthritis for sure, unless until you do a proper serology. And next, you will have a typical erosions, osteopenia, everything will start, and that's called established late rheumatoid arthritis. Established and late stage of rheumatoid arthritis. So this is the provocation phase. This is how the autoimmunity progresses. Initiation phase, where there might be only antibodies, there will be no signs and symptoms. Then you'll have a provocation phase, where your titers of antibodies will start increasing and signs and symptoms will start appearing. And initially you start with the early undifferentiated phase, then later on you start with established and late rheumatoid arthritis phase. Clear? Remember, the highest chance of remission, for example, is happening only if you treat in the early undifferentiated phase itself. Only if you treat in this phase itself, you'll have a highest chance of remission. Remember, for example, if you treat in this initiation phase itself, there's not going to be any much benefit, because very few of these patients only we move to the propagation phase. So we don't know which group of patients will go to the provocation of autoimmunity or progression of autoimmunity. Only few of these patients go. So treating all the patients is ridiculous. At the same time, for treating in the initiation phase, you need a screening test. And if you're going to use rheumatoid factor screening test, that's going to be ridiculous. Cost is going to be very high, non-specific, and that's not valid. And if you're going to use ACPA as screening test, again, cost is extremely high, and the sensitivity of ACPA is also very less according to our commonly used lab test. So there is no point in treating or screening these patients, but it's better that during the provocation phase, when the signs and symptoms start in the early undifferentiated phase, if you're starting to treat, there's a lot of possibility of achieving a long-term remission in these patients. If you're going to treat only in established or a late stage of rheumatoid arthritis, the damage is already done. And even if you treat the patient and the patient goes for remission, the deformities or joint problems that are already there is very difficult to reverse. So that's why it's better to treat in the early undifferentiated stage of rheumatoid arthritis itself. And one more important point I need to tell is that you have studied something called a Kaplan syndrome. This should be told at this point itself. You have studied something called a Kaplan syndrome. So you know what is Kaplan syndrome? It is nothing but pneumoconiosis with rheumatoid nodules in the lung. So what is the importance of that? So you know that pneumoconiosis is a risk factor, and the most common and the pneumoconiosis with maximum risk factor for developing Kaplan syndrome is silicosis. Even though it can develop with other pneumoconiosis also, but the highest risk of developing rheumatoid arthritis is actually with silicosis only. So if you have pneumoconiosis, you are having a higher risk of developing rheumatoid arthritis. If you have rheumatoid arthritis, there is high risk of developing RA nodules in the lung. And this development of RA nodules in the lung in the setting of rheumatoid arthritis and the background silicosis is what we refer to as a Kaplan syndrome. Which means one needs to know that development of Kaplan syndrome, the most important prerequisite is not rheumatoid arthritis, it is actually the pneumoconiosis. That's the most important prerequisite, not the rheumatoid arthritis. Rheumatoid arthritis come later because of the pneumoconiosis, because that increases the risk of developing Kaplan syndrome. So the basic need for development of Kaplan syndrome is actually pneumoconiosis, not rheumatoid arthritis. Please be very clear about that. Rheumatoid arthritis alone cannot produce Kaplan. You should have a pneumoconiosis, which is the most important thing. And at the same time, you might ask me why Parphomonas gingivalis is going to produce increased risk of developing rheumatoid arthritis, because this is an organism that is thought to contain paddy enzymes on its own. So this organism contains excessive paddy enzymes, and we know that paddy enzymes are something that are very commonly associated with the development of this rheumatoid arthritis. So probably that is the reason why this Parphomonas gingivalis has a higher risk of development of rheumatoid arthritis in this setting. Then, Saurabh is asking remission part. No. If you treat in early undifferentiated arthritis itself, then the chance of getting remission is more. That's all. Nothing else. If you go for the late stage, then the chance of remission may be very, very less. So after this, we need to talk about the clinical features of rheumatoid arthritis. And before talking about the clinical features of rheumatoid arthritis, I think you can go for a break and come by 7:30. Okay. Bye-bye.